내비게이션 얘기해 주세요.
하나 둘 하나 둘.
네, 다른 것도 얘기해 주세요, 델리.
델리게이션입니다.
수임 씨, 그 동영상 자료도 한 번만 틀어봐 주세요. 음향 들어오는지 확인할게요.
이것도
영상 자료 있나요?
Good afternoon. My name is Sungil Cho. I'm a professor of epidemiology at Seoul National University. I'm very glad to
네,
participate.
동영상 사운드 잘 들어옵니다. 유튜브 테스트 할게요.
Hello? 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 Hello?
Hello?
Yes. Hi, this is Francis.
여기 누가 말씀 한 번만 해주세요.
Hello? Hi, this is Francis.
Hello, this is Seoul.
I
말씀 한 번만 해주세요.
It's just a little insulting, but thank you so much. No. It's crazy. So you said you should be good. If you need anything, I'm gonna be here just a little while longer. Out the front door, go downstairs or walk behind you. I will leave my card right on the desk. Take it, because if you get locked up and anything, you can call me and I can bust you through. Thank you so much. Appreciate it. 죄송합니다.
Hi, Francis.
누구세요?
It's Era.
hi.
Hello,
Hi, Era.
Richard. We're just getting
Hi.
ready to start.
Hi. I made a couple last minute changes to my slide.
Hello. Is there?
Dr. Lee, how are you? It's
Okay.
Richard.
We're going to start. So, hello, my name is Mary Choi. I'm the president of the Korean American Medical Association, and I welcome you to day 2 of our 46th annual scientific convention. We have another full day of exciting program in store for you, and we'll cover really up-to-date hot topics, beginning with entrepreneurship in healthcare. And we'll also have the keynote speaker, Dr. Howard Koh, delivering his address, as well as Dr. Susan Bailey, the immediate past president of American Medical Association. We have the Women in Medicine Forum, and the day will be capped by the focus session on hospital medicine. So I hope you will enjoy, learn, and be inspired. And welcome and stay the day. So at this time, I will turn the podium over to Dr. Jennifer Lee, who is one of our member of the executive committee.
Thank you, Mary. Thank you, everyone, for joining us this evening in, I guess, U.S. time and in the morning in Korea time. It's my pleasure to introduce our first speaker of the morning in our first session of entrepreneurship in medicine, in healthcare. Dr. Richard Park is the CEO of Render Care, and I think needs no introduction to the U.S. audience. Also, the founder of CityMD. And thank you, Dr. Park, for joining us.
My pleasure. And good morning for those that are in Korea, and good evening to those who are in the US, depending on what time zone. But thank you for this opportunity, everyone. And I'd like to discuss a little bit about how physicians can harness the power and leverage of large physician practices. Just by way of background, I'm an ER doctor by training. I spent 10 years in the emergency room practicing, and then another 10 years after that doing urgent care in New York and New Jersey in particular. And then in 2019, I left, and with my co-founder, In-sun Hwang, a private equity firm dedicated to investing in vulnerable populations. So provider groups caring for vulnerable populations. And so this is a topic that is near and dear to my heart. How do you harness the influence and the power of physicians that scale? How do you predictably, reliably scale physician practices? So if we may, I'll kind of break the conversation into 3 parts and 5 minutes for questions. The first part is sort of a case study on CityMD, the urgent care chain that my partners and I co-founded and led. The second part of the conversation is Render Physicians. Render Physicians is a Chinese primary care practice here in New York. And then the lessons, the challenges, opportunities, the fixes, lessons learned from those 2 experiences. So if we could go to the next case study in CityMD. So before we move on to the next slide, a little bit about CityMD. CityMD is an urgent care chain. And so as ER doctors, we wanted to care for patients in a retail setting. Now, after high school, I ended up not going to college right away because I couldn't afford to go to college. And this is 1990, I opened up a 1-hour photo store. And that became the family business. And Koreans at that time in New York that either did, we always did, fruit stores, we did nail salons, dry cleaners. At that time, 1-hour photos was kind of popular. It's interesting, the same approach to 1-hour photo, once I went to medical school and became a medical doctor, we took that 1-hour photo approach and made it into 1-hour medicine. And CityMD was a retail medicine business. We opened on the ground floor, and we took in walk-in patients. No appointments, they just walked in, and we were able to see them. In 2021, I left in 2019. When I left CityMD in 2019 as a CEO,
we had seen almost 3 million visits in that year. Due to COVID, not just us, but almost all urgent cares across the country doubled in volume. So this year, CityMD will see 6.5 million visits in 150 locations, roughly. And what we're most proud of is the fact that it continued to scale. In fact, to my sadness, but pride, even after leaving at 3 million visits, it's doing better than before. It's doing better than ever without me. And the lesson there is, how do you create something that, as physicians leading it, that predictably, repeatedly scales? And today, the 6 million visits is managed, hopefully, in a tight band between wait times, net promoter scores, and patients' problem. A whole bunch of metrics, but we're able to keep every location very standardized. Next slide, please. And so the lesson we learned at CityMD is sort of the retail hospitality model. How do you get 650 physicians at the time, at least in 2019 when I left, how do you get them all centered around doing the same things? How do we get them all to wear a white coat? How do we get them all to obsess about patient satisfaction? How do we get everyone obsessing about wait times? And so we put in standards. CityMD, when we first started in 2010, we had one office in 2012. By mid-2012, we had 20 other urgent cares that had similar approaches to healthcare. And we took 20 practices and we merged them and forged them into a single practice. So 20 different groups practicing urgent care differently. How do you get them all to align, become a single entity? And when you do that, there's power to that 문차이, right? There's, how do you get them to consolidate? Because when you consolidate, the benefits of consolidation are multifold. When you consolidate, you move together, right? You move together. There's consistency to your quality, to your risk scoring, to all the data. There's a consistency because everyone does things the same way. It makes things repeatable, predictable, and scalable. And so practically that leads to better rates. To care for patients and to care for doctors, you need better rates. It's no secret. But by moving together, you have a much better shot of getting better rates. Repeatable. So the first office, second office, 150th office, it became so easy to open. Open one a month. It became relatively not thoughtless, but didn't require a lot of energy. It just happened because it was repeatable. Physicians don't like to standardize. They like to do things a little differently. They like to be partners. Partnerships by nature are a little bit different. And so when you're different, even slightly, it's hard to repeat those. So standardization became a key element of what we did. So when you're standardized and repeatable, you become predictable. Predictable, what does that mean? We knew at CityMD, every time we opened an office in Manhattan, we can almost, plus or minus 5%, we can guess how many patients we'd have in the first day, first week, first month. It became predictable. We knew that for every dollar we put in, we put $1.5 million in to open a CityMD. We knew that in Manhattan, that within 12 months is a payback period, 12-month payback period. We knew that if we opened in the 5 boroughs like Queens, Astoria, the Bronx, we knew that was a different payback period. It was very predictable. We knew that we opened up in Long Island, it was a 20-month payback period. Not only that, you get to predict how many referrals, how many orthopedic referrals, how many primary care referrals, and then the downstream hospitalizations. Everything became very predictable. That predictableness became very valuable. Good companies are able to predict. Good companies can predict and plan. So that was the CityMD experience. We'll move on to the next slide if you don't mind, please. Introduction to Ascend. I'll spend 10 seconds on this. My college friend, Insung, who used to lead global healthcare at Warburg Pincus. We started our own private equity fund. We're investing in vulnerable populations. Vulnerable populations in New York are the elderly and the poor. And in New York, at least, the poor and the elderly are ethnic. They're Hispanic, they're African American, they're Indian, they're Asian, they're Chinese, and Korean. So we invest along ethnic lines in mostly government-sponsored plans, Medicare and Medicaid specifically. Next slide, please. So that's my partner. We have a team. Slide after this, please. And as such, Ascend Partners invested in an MSO. It's an organization that helped to augment and provide services for our portfolio practices. And so our job is to help these physicians take risk. I'll give you an idea. It's led by Michael Carson. Michael Carson is not a physician, but there's a lot of physicians on board here. But Mike Carson was a former CEO of Harvard Pilgrim up until recently, and he has a long payer history. But how do we, as centralized management services, help our providers understand the importance of standardization and normalization? And that's our job here. Next slide, please. Some of our advisors, but mainly here, I'll just mention one in particular. They're all important, but one of particular note, Brian Leclerc. Brian Leclerc spends about 2 or 3 days with us a week, 2 days a week with us. But he was a former CIO of Humana for, I don't know, 15, 20 years plus. How do we get accurate data and dashboards so we can incent and properly align our physicians? That's an important thing, and I'll touch more upon it later. But in particular, between Brian and Anish Chopra and the rest of the team, how do we accurately manage data so that we can create accurate dashboards that can therefore accurately incent our providers? Next slide, please. I want to talk next a little bit about Render. Now, Render is a group of 17 practices in New York City, all mainland Chinese doctors, essentially a mainland Chinese practice. 17 practices that in 2020, last year, in August, we took these 17 practices with 80 doctors and roughly 100,000 patients in 30 locations. All practicing independently to 15 to 20 years, very successful, and we merged them into a single TIN, tax ID, a single practice. And what that means is it's no longer my cup, it's 5% my cup and 3% your cup. And instead of me and my practice, it became we. How do you get everyone working together? And when you do that, you can have better results. If we could move to the slide that is labeled United Medicare, slide 12, a few slides above, next, just the time. Here we go. Let's slide prior to this, in fact. So by standardizing everyone, we were able to increase quality scores. If we can go to the prior slide, we took 5,000 Medicare patients from United, and when we started, we had a quality score. For those of you that are in the States are familiar with HEDIS metrics in the Medicare world, we started at a 3.15 quality score. This is slide 12 in the deck, by the way. We started with a 3.15 quality score. And in 4 months, we were able to get that group to 4.7. And how did we do that? Why did we do that? When your HEDIS metrics are better, the payers get paid better, patients get better care, get better reimbursed, and care for your patients better. So from 3.15 to 4.7 in 4 months. And of note, our best performer, Dr. Han Bin, he was traditionally at 4.5 stars. He is today at 4.95. If you take the practice average of 4.7, it's better than our best. That's what you call something repeatable, scalable. And therefore, every time a physician joins us, that is our goal. Every time a physician joins us, we predictably, repeatedly, quarter after quarter, improve them in a predictable way. So when a doctor joins us, we have a goal that in a year, they get to steady state like everyone else, whether it's quality scores or risk scores or the ability to wear red ties. Whatever the measure is, it's the same basic principles. You incent properly, you measure, and you manage. A little bit about Render. It sounded, so how did we do this, and what were the challenges that we faced, and what are the lessons learned? When we first encountered Render doctors, nobody used email. Nobody used email consistently. Not the staff, not the doctors, so there was no communication. Number one. Number two, everyone did things differently. Their EMRs were all over the place. They used similar EMRs, by the way. They use actually, most of them use the same EMR, but they used it differently. I'll give you an example. In our EMRs, when patients were registered, we had 1,000 different names for insurance companies. Everyone spelled it differently, everyone used them differently, there was no standardization. So early on, when you asked us, how many United Community Plan patients did we have? How many United Medicare Dual patients did we have, or MLTC? Could not answer a single one of these questions because we had to clean up. None of our data was accurate. It makes it really hard to manage when none of the data is accurate. And so step by step, ground up, we whittled that list from, it took us 4 months, from 1,000 to 40, much more manageable. Now our data is more accurate, not perfectly accurate. That's an example. A second example of this is when we came into these doctors and they were really wanting to take full risk on their patient population. They want to take full risk because you may or not know this, but the Asian population in America, not just here in New York, but Korean, Chinese, Vietnamese, it's a very low MLR population. And so Asians can take risk, more so than any other population in the country. They want to take full risk, but literally when you go into their offices, you find nobody knows their passwords to their own computers. And when you do, and this is not exaggerating, we found Windows 95 or some version of early Windows. You cannot take risk or do anything sophisticated when you don't invest in basic infrastructure. So what we've learned is by investing and executing on the basics, email, Windows 95, nomenclature of names, data dictionaries, that's what it takes. And all the artificial intelligence and fancy gizmos and technologies can't fix it. These insurance companies and the government are asking these providers of ethnic patients to do very sophisticated medicine. They're unequipped, underinvested. It's like when a major league pitcher goes to a schoolyard and throws 85-mile-per-hour fastballs at a child. And when they can't catch the ball, they think the answer is to change and get a new pitcher, right? Or throw a better fastball, a faster fastball. The problem is not the pitcher, it's the receiving end, it's the catcher. To succeed in government-paid Medicare and Medicaid, in the government-paid environment, physicians have to invest in basic infrastructure. And that's what allows these performances to improve. It's not anything sexy, it is basic industrial infrastructure. Let's move to a slide that says lessons learned. Lessons learned. Here we go. Perfect. We can advance to the next slide. And so we know this to be the fact. Our philosophy is with better coordination or control is better performance. And I'm listing some of our portfolio of partner companies that Ascend is invested in. And on the x-axis is control. As you go to the right, more control. So you have independent doctors that are on their own. They're not part of any organization. A little bit further up in the coordination of control food chain is IPAs, Independent Physician Associations. There are doctors that stand close together to improve quality scores and share rates, in all honesty. A little further down, we've also invested in a company called, a practice called Consensus Health. It's in New Jersey, and it's 108 providers. Now they're singleton, meaning they all bill under a single tax ID. They all use the same EMR, the same governance, but they're federated, meaning each practice kind of runs as its own mini autonomous state. It's like the United States. You have federal and you have state control. To the very extreme on the right render, this follows more the CityMD model. It's top-down physician leadership. And when we say everyone wears a red tie, everybody wears a red tie, in theory. It's much more consolidated and therefore better controls. And when you have more control, you have better performance. It's no surprise. You're able to standardize and normalize. The better you can standardize, the better your performance. Lesson learned. The second lesson learned is not everybody wants to be. Not every 40-year-old physician wants to be or lose their autonomy or give up their keys. So some of them want to be independent. Some of them want to be part of IPAs. Some of them want to be in a consolidated team, but in a federated state model. The second lesson is you can't force doctors to do what they don't want to do. You have to work with them where they are. A 40-year-old specialist is different from a 50-year-old primary care doctor, is different again from a 65-year-old primary care doctor. Different needs, different wants, different needs. And so we need to find a place, and there's an opportunity for every type of doctor. The next slide, please. Our goal is every time a doctor joins us, quarter upon quarter, we improve them. And the different lines represent the different types. The bottom line, the 2.5, is independent doctors. On their own, they'll do 2.5. An IPA might do a little better above that, that gray line. The orange line above that is federated singleton practices. And of course, we believe the best results come back from sort of a command and control approach. Lessons learned, more control, better results, but you have to involve physicians. It's easy to say, but execution of the basics is very hard. It's a long road to a simple thing. We found that you need physician buy-in, you need physician leadership. You always need that godfather doctor that, for whatever reason, the doctors around them trust. For whatever reason, the doctors around them gravitate toward or listen to. And without that doctor, these things are hard to do. You can say them, you can standardize, you can want to do all these things, but without the right physician leadership, it's hard to do it. That's lesson number one. Physician leadership is paramount. Number two, these physician leaders have to be able to augment their weaknesses or strengths with complementary skill sets, oftentimes not found in physicians. So you will need a CFO, you will need a marketer, you will need an IT person, and you have to know and understand how to work with non-physician professionals. And finally, if I had to say another lesson learned, the size is only important if it's coordinated. Standardization, predictable, repeatable, scalable is how physicians can take back some of the influence they've lost over time. Because we spend all our time studying, caring for our patients. And quite honestly, we're at a disadvantage when compared to those that spend a lifetime in finance and understand how to use leverage and the financial markets. We are at a distinct disadvantage. And so physicians that are able to learn this skill, a rare find and incredibly valuable. So with that, I'm going to pause and see if there's any questions. I apologize, I may have gone over a little bit over time.
Thank you, Dr. Park. A truly inspirational and innovative talk that you've provided for us, certainly very near and dear to my heart. But as a practicing hospitalist in an academic setting where we don't have great control over the data or the work environment in which we provide care to our patients, you did mention meeting different physicians where they are, something that is very challenging for many of us who are again, are not in control of our practices. Can you describe some of the best practices or a best practice in particular to help align physicians and to change physician behavior?
How do you align physician behavior? It's incentives, the right incentives, the right dashboards, and the right management. And I'll give two examples. At CityMD, over 6.5 million visits this year, we're able to, maybe not this year, 2 years ago, 3 million visits. COVID's been a very difficult time. But 3 million visits, we're able to control wait times to a very narrow window. It's a very complex thing to do, yet we were able to do that across 150 locations. Early on at CityMD, what I was unable to do was to get our doctors to wear white lab coats. That's all I ever wanted. No matter how much I threatened, cajoled, begged, and pleaded, I could not get these ER doctors, because I'm an ER doc, to wear white lab coats. We like scrubs and parachute pants and stains everywhere. Today, I think we can do it. Today, I would say every hour you wear a white coat, there's $5 for you. Number two, it's going to be on a dashboard that you could be pushed to your email, but you're going to check. It's available on your smartphone, a dashboard, a CRM, where if you wear your coat for 8 hours, it'll say 8 hours, and it'll say $40. Right? So number two, it's going to be accurate. When you wear it for 8 hours, it's not going to say 7. It's going to say 8. Because if it says 7, the doctors get upset and they'll sabotage it. It's remarkable. And number three, in 2 weeks, we're going to pay you. Those are the incentives. Now, those are easy things to say, but to accomplish when you're Windows 95 and you can't, how do you know they wear for 8 hours, not for 7 or 6 or 10? It's the accuracy of that, and that's the operation, that's the execution of it. And then finally, what we would say is, for the top 25% of the performers, of the best coat wearers, you could forego those equity, you could forego those bonuses and make it equity. Now you become a partner for the top 25%. Incentives have to be smartly done. They have to be accurate and measurable and under the influence of the physician, and has to be timely paid, and ideally tied to ownership. I would get 90% of my doctors to oblige, I think. And how do you take that approach? That's the same approach we took to HEDIS metrics. Same metrics we're going to take to RAF scores now in primary care.
Thank you, Richard Park, for joining us this morning and for providing us a great segue into our next session. Thank you.
Thank you for listening.
And with that, we'll turn to our second session of the morning, Technology in Medicine, as we hear two other developments in the application of technology to the fields of psychiatry and surgery. And joining us as our first speaker of the session, Dr. Francis Lee, who is chair of the Department of Psychiatry in my home institution, Weill Cornell Medicine.
Thank you so much. This is both a wonderful opportunity and an honor to speak before all of you. I would like to thank the organizers. And I would like to spend the next 15 minutes just going over some recent advances in technology and neuroscience in the field of psychiatry. But before I do, I just want to go over some of the two major forces that are shaping these efforts. First of all, psychiatric disorders have an enormous economic impact, probably even greater than cancer and cardiovascular disease. And there are many reasons for it, but the main one is that most of the disorders emerge during adolescence and young adulthood. All our treatments take a long time, and we have a significant issue of access to care that we don't have enough providers. As an example, 1/4 of American teens have an anxiety disorder, and we only have 8,000 child psychiatrists in the United States. Second, The pandemic, in addition to creating an immediate mortality and morbidity due to the virus, has led to a second wave of morbidity, which is one related to psychological trauma and increases in rates of mental illness. And this was really borne out this recent October, where the American Association of Pediatricians essentially declared a national emergency in children's mental health. And yesterday, the Surgeon General actually also had an advisory highlighting the urgent needs to address the nation's youth mental health crisis. So it tells you that essentially the pandemic has had this significant negative effect on our population related to mental health. And the question we have is what can we do given the fact that we have operated in psychiatry with a traditional model, for example, of everyone needs to see a provider, everyone needs to go to psychotherapy for a certain amount of time. And what we have been doing, especially at Weill Cornell, is trying to figure out whether we can actually come up with a digital version of psychotherapy that would be effective. And again, this one would be one in which we would create a therapist-free cognitive behavioral therapy app. And I'll spend the next few slides going over this. So the problem in the current mental health app field, if you go to any of the app stores, is that there's almost none of the apps that are currently available have any research support. And also 80 or more than 50% of the apps available, no one completes because there's lack of engagement. So you have both lack of evidence and lack of engagement. And about 3 or 4 years ago, we realized that while there was intense promise within the digital space in terms of expanding access for mental health care delivery, that these were the hurdles we had to deal with. And so what we did was we essentially went and tried to create an app that would be engaging, would tap into our advances in neuroscience, and also be able to do essentially the core evidence base of cognitive behavioral therapy, which is the core way of treating people with anxiety and depression at this stage. But instead of me telling you about the app, if I can do this, if I can figure out how to work this, I'm going to show you a video of how this app actually works. Let me see if I can do this. And this will only be 90 seconds.
Hi, I'm Maya, and I'm a therapist here in New York City. I've been created by a team of clinicians and researchers who help people just like you. I'll be walking you through this program as you learn about anxiety and depression and how treatment works. And then you'll learn skills to manage your own symptoms. Throughout this program, you'll see Erica. She represents the many people who have gone through things similar to what you're going through. So let's get started. You're likely here because your feelings, emotions, or physical sensations are getting in the way. Yet, how well does it work when someone says, "Don't worry about that," or "That's nothing to get upset over"? Not so well, right? Pretty frustrating, actually. So how can this program help? We rely on the connections between feelings, thoughts, and behaviors, and the influence each has on the other. We'll focus on shifting the way you think about things and making sure that your thoughts are as realistic as they can be. We'll also work on some of your behaviors. We'll teach you how to face challenging situations, even when you feel like doing otherwise. Shifting your thoughts or cognitions and engaging in new and different behaviors will likely shift the way you feel as well. That's what cognitive behavioral therapy is all about. And you're not alone in this. About 30% of people will struggle with an anxiety disorder at some point, but many suffer in silence, just trying to power through, and it often doesn't work. Cognitive behavioral therapy can be very useful for helping you learn to handle your symptoms and get your life back.
So this, I won't go through the details of this, but essentially it has all the key elements of what the evidence base has shown has been effective for cognitive behavioral therapy. We've actually run a pilot clinical trial. This is probably one of the first clinical trials that have been run. We've actually done, I won't show this, neuroimaging before and after giving this cognitive behavioral therapy app for 6 weeks. They have to do 2 sessions a week. And what I found most amazing is that within our subjects who had anxiety disorders, we had 80% of the participants found it very engaging, 72% finished the app completely, and most importantly, the decreases in their scores on depression and anxiety were equivalent to in-person psychotherapy. So this is one of the first evidence that we can actually use a digital tool to actually replicate what has been done in person with cognitive behavioral therapists. But we do know that we got very lucky getting such a high engagement rate. So we actually have partnered with behavioral economists at the University of Pennsylvania, in particular Kevin Volpe, and that we have now begun embedding different types of incentives within the app. And in particular, I'm very excited about the fact that we're putting in social incentives so that groups of patients will actually do the app together or encourage each other. And I think these are the types of questions we want to answer. What are the right mixture of incentives that we can embed within such an app? And after making this app, we've actually broken the app down into different parts so that we can actually in the future give this app for not only to do research studies, but give it to students, use it in our inpatient units, use it in our outpatient clinics, and ultimately, hopefully be able to provide different skills and use this as a platform and to deliver targeted evidence-based psychotherapy for our patients. I want to just stop there and say that this is something I think that will ultimately allow, it might not replace psychotherapists, but will allow us to expand the access. Another form of psychiatric disorder is one called late life depression. And what we were able to do was actually find a very specific cognitive disorder in here. And another part of our digital innovations team has actually developed a video game called Evo to basically try to increase cognitive control or cognitive executive function and by playing this video game. And they did a head-to-head study. Let me see, my computer is getting slow, but essentially so you either played this iPad game for 20 minutes a day for 4 weeks, or you saw a psychotherapist for 8 weeks, once a week. And what they found was that just by playing this video game, that you actually had increased executive function and a significant reduction in mood. If you saw a psychotherapist in person, you only got a reduction in mood and no effects on your executive function. And most importantly and most excitingly, this has recently been published, that they also got increased functional connectivity within a cognitive control network around the prefrontal cortex. So this is, again, another example of how not only can you get improvement in behavioral health, but you can actually get changes in brain connectivity. And I think this is another way to think about how two potential digital interventions that could essentially change the way we treat our patients. And I'd like to end by talking about another sort of area of psychiatry which we have fallen behind with other fields of medicine, which is that we do not currently have a biomarker for diagnosing patients with anxiety disorder, depression, or schizophrenia. We always thought, like the rest of medicine, we would find a genetic test. We would have a blood test at some point for some of our disorders, and we have not been able to find this. What I want to tell you about is a story about how we actually think we have found an AI-based neuroimaging biomarker, and which is now currently in the final stages of an FDA-sponsored trial. And the way to think about it is, for most of the last 100 years, the way psychiatrists have thought about patients is that we would look at symptom clusters, and then we would essentially think that we have subtypes of certain psychiatric disorders based on the differences in symptoms. What we actually think is going on actually in these brains is actually that there is a change in circuits or hubs within the brain. And that is actually the differences between the patients, not their symptoms. It's sort of the connectivity patterns within their brain. And I think the big sort of technical advance occurred about 15 to 20 years ago, where using functional neuroimaging, they found that just looking at blood flow was a great sort of marker of neural activity. And I think the best way to explain this is that this is a sort of an airport map of an airline, and you can see that for, I think, most of the last 50 years, we in psychiatry have been thinking that we should study the airports, these brain regions. But what actually is most important is actually the traffic between the airports, because they ultimately tell you where the hubs are. And this is what actually we think has happened with the brain with disorders such as depression, that, for example, if you have bad weather in Chicago, there will be a separate type of effect on the network if you're, for example, United Airlines versus another airlines that had a storm in Atlanta. You would have a different set of hubs within the brain going down. And Connor Liston at Cornell basically took 1,200 scans of patients with major depression and controls and used machine learning to basically come up with an algorithm to basically subtype depression in these patients. And most impressively, this was published a few years ago, he's been able to use this algorithm to basically correctly diagnose patients to an 85 to 90% sensitivity and specificity. So you're getting very close to the numbers you need for a biomarker. But I would say that the main problem with just using a very advanced neuroimaging scan is that most psychiatrists can diagnose depression this way. But the reason why this is such a breakthrough, let's see, I'm just waiting for my, is that you can, there's a form of treatment called transcranial magnetic stimulation. It's FDA approved for depression. And what he found is that he can use this algorithm to find a subtype of depression that will respond 80%. The normal response rate for TMS currently is 30%. So basically, but by using this type of neuroimaging scan, we will in the future be able to personalize our treatments and give more effective treatments for our patient population. Let's see. I'm trying to read. So I think in summary, this last part of the talk, what I wanted to suggest is that in psychiatry, we're using now technology, both in terms of advanced neuroimaging, but also AI-based machine learning to not only subtype our patients, but basically use it to make treatment decisions, not only for things such as transcranial magnetic stimulation, but also to give certain subtypes of digital psychotherapy, which I did not bring up, but I could be more than happy to discuss. Anyway, thank you so much. I think what I would just like to end by is saying that ultimately in our field, technology is helping us now think and rethink about some of the traditional assumptions about how we see our patients and how we diagnose our patients. And I'd like to stop at this point. Thank you so much.
Thank you, Dr. Lee. We will save the question and answer period for after our next speaker, Professor Gun-Ho Rah from Yonsei University College of Medicine. Professor Rah is the Professor of Urology and Robotic and Minimally Invasive Surgery Center. Thank you for joining us here today.
Thank you, Dr. Lee. It's so nice to be back at the CAMAS convention. I remember 2 years ago, it was hosted in New York City, but we never expected this pandemic would come to us. But so nice to see everyone in person here in downtown Seoul this morning or this evening in the U.S. One of the changes I have to disclose, I made a job change. I recently moved to Naver. Those of you who do not know Naver, this is the search engine company which is has a #1 market share in South Korea. It's the #3 market cap company here in Korea. It also has a very strong messenger arm called Line in Japan, Thailand, Indonesia, and Taiwan. So I'm very excited to have a major change in my life. And actually, I submitted a presentation about the new surgical aspects before when I accepted the invitation. But thankfully, to the organizers and scientific committee, I had an honor to change my presentation about the digital healthcare, the viewpoint from the company's point of view. So I define the medical industry as four aspects. One is the pharmaceutical industry. Second is the medical device, such as a robotic surgery that I've been doing for the last 20 years. The number three is the digital health. This is the digital health era. And the fourth is a probably up and coming area is the public health. In US terms, I guess it's how to optimize and bring more efficiency in Medicare and the Medicaid communities. So I'll be focusing on digital health, the number three aspects this morning. So I believe in digital health, we have four major areas to explore. One is the interoperability and the PHR or the EHR aspect. Second is the total health. As we all know, the patient care does not stop at the clinic or the hospital. It has to be a continuum, the delivery of care. And the third is the digital medicine. Professor Lee just recently nicely summarized the behavioral health aspect in the presentation. And number four is how to make our jobs easier as a physician. I was somewhat frustrated to practice in South Korea, where I have to see up to 100 plus patients per morning in 3-hour session. So it's just overwhelming. There's got to be a better way that we can serve our patients better. So I think that was a major motivation why I moved to the company and joined with the engineers and tried to bring up some solutions for us. The first is the interoperability. I think as we all know, there was the fax era, everything is not communicated very smoothly. But I visited the States in September, a few months back, and I've noticed a very interesting phenomenon. Some of the major academic institutions now are umbrellaed under the EPIC EHR. So some of our friends are now saying that it's not too bad, it's not too bad. And that means that's a great change. When something changes in medicine and someone does not say a negative feedback or adverse feedback about something before, that's a great change. So I think I would not be surprised. Maybe next year's convention, we'll hear so much things about how the EPIC world has expanded. So I think that was a great change that I've noticed 2 months ago in the States. But there are examples. This is the example in the country of Estonia. It's the Baltic country, small Baltic country. But they have consolidated all their healthcare data into a total nationwide system. So they can do prescriptions, clinics, ER management. So this is the most advanced, a nationwide the healthcare information portal. Here in Korea, earlier this year, we launched a app called the government-sponsored app called the My Healthway. This is a continuum of the process of the consolidating the financial data. Here in Korea, all the banking records are interchangeable. So you can look at all your bank data with any app. To do that in healthcare, the government launched very ambitiously to provide a government-sponsored app where you can access 4 different data sets. One is the prescription record, and the clinic visit record, the vaccination record, and then the South Koreans are mandated to have the government-sponsored physical exams every 10 years or every 2 years, depending upon your age. So all these data sets are available to you, and try to make them open to companies like us or the insurance companies. But they're discussing about how to guarantee the safe exchange of this health information in South Korea. So it will be very exciting that whether we can pull through this very courageous effort. The second portion is the total care. How we can, we have this misconception from our patient community that we are not interested once our patients leaves our clinic. That's not true, as we all know. We are worried and we are curious, but we just don't have time. We just don't have any resources to do that. So how to do that is we can probably bring some technologies to it. This is an example, the Omada Health, where you can have the health records coming to your app and communicate it through your coaches. The second is a more advanced type. This is the Wellbe My Card in Japan, where this actually rigorously involves the physician arm in taking care of these the informations after clinic. So actually, it can give you a straightforward the informations to the EHR the physicians use. I think this is one of the most advanced systems where it integrated the physician's clinic into the everyday life. We know that Apple Watches, the Galaxy Watches provide tons of information, but as a clinician, we need to have a summarized report. We just cannot look through all these different information. We can probably look at one sentence. So they are trying to do that in a busy Japanese clinic setting. The third portion is a digital medicine. It overlaps with the Professor Lee's previous presentation. I think this is a somewhat exciting to see, but it's hard to have the reimbursement because of it's hard to justify the efficacy and the cost effectiveness. So the paratherapeutics has been, I think recently, this month has been approved by the market. It successfully went on to IPO. And then this is one of the apps, those of you who are familiar, this is used for the addiction and insomnia. And then the second exciting area might be the exercise apps. The company Naver is a very young company. The mean age of our employees about 35 years old. And their number one problem is, as they're heavy computer users, they have a video display syndrome, the wrist, the neck, and the back. So we do have a huge problem in our own company setting. So there are various apps. We can do these better. I was thinking about maybe putting a camera on your living room, on maybe a mirror or the window. You can do a nice exercise in this COVID world where it is not quite safe feeling to visit your everyday gym like before. So I think these are very exciting, solutions we can adapt. And then the similar various apps, we just been introduced over the Evo app to cure addiction by another addiction, video game. So this is an exciting technology. And the fear of the acrophobia or the social phobia, these can be done nicely to simulate a setting like the podium setting with a VR technology. Lastly, I'm interested in how to make our jobs better as physicians. So there are various things. Let's say the office recommendations, examine reports, voice EMRs, EHRs, e-prescriptions. So there are so many areas we can tackle upon to make more efficient way to deliver healthcare. So one of the things in UK is by the National Health Systems is the Babylon Health. So it's like 20 questions. You can go through this app and you can find your suitable primary physician or experts through this app. And it's not surprising that the Google DeepMind, where the AlphaGo, came from UK because this is a huge health spending in the country of Great Britain to modernize their health. As we all know, the Microsoft has acquired close to $20 billion earlier this year, the Nuance. I'm not going to go deep about Nuance, but one of the things I've seen in September in the States is that You probably, our U.S. colleagues are overwhelmed by the 21st Century Cures Act, where the information is readily accessible to our patients. So how to communicate within clinics among our assistants, administrators, nurses, and among our physicians is a great challenge. And I think Microsoft has a clear strategy using their Microsoft Teams to have a secure line along with the nuanced technology. So I think my hats are off to Microsoft. I think they're in the right track compared to the Google, where Dr. Feinberg recently left to Cerner. So this is another exciting area where the tech giants are tackling our healthcare industry. Lastly, there are so many interventions about the imaging area. Just 2 weeks ago, there was a North American, the radiology conference in Chicago, so everything was AI. But I think it will be exciting. But at the end of the day, it has to be, if you have a technology should be successful in healthcare, I believe it has to do one or two things. One is you have to make physicians and healthcare professionals make more money. Second is that you have to make them job easier. So if you can do both, you will be hugely successful. So I think all these the glimpse of the technologies that I've introduced this morning, it's just the tip of the iceberg. You'll be expanding. The company feels that the Naver is founded in 1999, same time as the Google and all these internet companies, Yahoo, here Empath or Lycos. I believe the healthcare is right now 1999. There are so many apps, so many solutions are coming out. It remains to be seen that not all solutions will survive, but it will be market tested. But at the end of the day, we'll have days like the smartphones and then the Netflixes or the YouTubes. All these the exciting technology will come to us in healthcare and will make our professional jobs more easier and serve our patient communities better. So thank you so much for this morning's opportunity. I look forward to attend the Korean Medical Association in the next years, the years to come. Thank you very much.
Thank you, Dr. Ra. And we'll bring Dr. Lee back on for our Q&A section for both of our speakers. And please feel free to enter questions into the YouTube chat and also our in-person audience. We do have microphones available for you, so please raise your hand. Both Dr. Lee and Dr. Ra, your talks touched on both the use of technology to address the challenging and very pressing issues that all of us face, I think, across the globe in medicine regarding timely access to care. In America, we are also faced with another challenge of providing care and providing equal access to all of our patients in the growing light of addressing the disparities that our societies face. And there is concern that these technological advances may further increase that divide. Do you have any thoughts or suggestions on how we can actually use the technology to close that gap? Dr. Lee first.
So that's a wonderful question. Well, first of all, I think that through the generous support of Weill Cornell, we've built this CBT app through philanthropy. And so our plans are to actually distribute this app for free within our clinics. And we've also are distributing it to our medical students and graduate students. But I think what it will do, hopefully, with these types of apps, at least for whether it be for addiction or for anxiety or depression, is that it will allow a provider to see many more patients than they would normally see, so that they could actually have it almost as a helper, as a digital helper. And I think that's how I think access will be, so that one psychologist in a pediatric clinic will now be able to see many more. And what's so wonderful about these types of apps or these types of treatments is that this is the best evidence-based treatment we have in psychiatry. So that everyone is getting it's the same exact treatment. And I think, but again, implementation will be the key, and it's whether our patients will engage with it is still an open question. But I think when we built the app, we were thinking of it as neuroscientists and as biological psychiatrists, but ultimately we hope it will also address the access issues also.
Thank you. And Dr. Ra, any thoughts?
Yes, I totally echo Professor Lee's comment. I think there has to be two entry points in technology and medicine. One is that half of our days we spend with the EHR or some form of a working program. So all the patient information, anything we want to see about our patients should be incorporated into our platform. So that's number one. Second is that I work at the internet company, so this is my cell phone. And we have a aspiration to include all my health data, the Weill Cornell, Yonsei, or any primary clinics I visited. If I can see all those data sets here in my palm, I think that will be very successful. As a company, we would like to sort it out, condense, and make a one-page report or one-sentence report that our physician colleagues can just look at one-page report. If I'm interested, I can click on and pull down all the other information. It goes vice versa. So it's not that we do not have information to treat patients. We do have too much information. How to condense and make our jobs easier. I think that's the industry job, and I'm very excited to speak on behalf of the Korean physician who works at a company. Thank you very much.
Thank you. Thank you, Dr. Lee. In the interest of time, we'll move to our next session, and I'd like to introduce our moderator, Dr. Michelle Kim, the convention chairman for KAMA 2021.
Good morning and good evening, everyone. It's my pleasure to start this next session, which is the Dr. Wang Ki-hong Memorial Lecture. And this lecture will address the future of cancer management. I now invite the chairman of the board, Dr. John Won, to come and give us the commemoration for Dr. Wang Ki-hong. Dr. Won?
First, thank you very much, Michelle, and day two. So congratulations to Mary Choi and the rest of the EC committee. And I want to welcome all those in the United States and in Korea this event is being streamed live. I was left with the Dr. Wang Ki-hong introduction, which is not an easy thing to do in this limited time because he was such a giant in his field. But I'll try to do the best I can. Upon his passing in January 2019, and what he meant for the Korean Americans, we decided the best way to honor him is to start a memorial lecture series. So we had our first one in 2019, and this is actually the second one. As you know, he was a pioneer and a giant in medical oncology and cancer research. And I think he personified the Korean American dream and success at its really the finest. Prior to his passing, he was the head of a division of cancer medicine at University of Texas MD Anderson Cancer Center, where he oversaw 17 academic departments and more than 350 faculty. He's a graduate of Yonsei University College of Medicine back in 1967. His accomplishments throughout the career is simply mesmerizing, and it's really beyond the time allotted here. His groundbreaking work on the management of advanced laryngeal cancer with chemo and radiation is still the standard to this date. His work included over 70 million in research funding, over 700 scientific publications, and multiple citing throughout countless journals. He contributed to 11 textbooks, served on editorial board of 17 scientific journals, and he trained many of the residents and fellows who are now leaders in their respective field. His recognition includes Hoan Prize in Medicine back in 1994, Medal of Honor Clinical Research, a member of the Academy of Medicine, and so on, which I am just not going to mention. But the main reason why this memorial lecture was started, like I said before, is not because of all these accomplishments he had, but more importantly because what he represented as a Korean American who immigrated to the United States. His story represents a personal struggle and hardship. He had to overcome at a time when there were hardly any Koreans, even in major cities like Los Angeles or New York back in the 1970s. I vividly recall seeing a picture of him getting off a plane with his family for the first time in New York, and it could have easily been my own father and mother coming down the ramp to touch the American soil for the first time. When Dr. Hong and Mrs. Hong traveled to New York in 2015 to accept the Kama Lifetime Achievement Award, which was the first time that was given. I remember him distinctly telling me that when he first got here, he wasn't even really taken seriously as a physician and even doubted his qualifications to practice medicine. Instead of being discouraged, knowing Dr. Hong, he worked and worked, and as they say, the rest of it is history. You and I are faced with a lot less obstacles and struggles because of the people like Dr. Hong who paved the road for us and other first generation who's really helped us achieve our success and where we are right now. And this is one of the fundamental building foundation of Kama and why we exist. And my father-in-law, Dr. Hyuk-Sung Lee, and Dr. Hong actually both served together as a in the Korean Air Force as flight surgeons. And I distinctly remember my father-in-law telling me that Dr. Hong, from the beginning, knew that he would accomplish many great things in his life and how right he was. And I believe Dr. Hong is in part of us in some form or shape. And it's been a really honor to know him, and I hope his legacy will continue on, and this memorial lecture will continue. So thank you very much. I want to show you some brief picture because no one knows this, but this is Dr. Hong, kind of next slide. And that's during the 2017 Washington, D.C. convention with Dr. Ko, Dr. Hong on the far right. And next slide, real quick. And this is the Lifetime Achievement Award with the executive team at New York City. And the next slide. Now, how many of us get to do this? Ceremonial first pitch, Dr. Wang Ki-hong. By the way, one thing is a fact that many of you may not know. He's a diehard baseball fan. That's his really passion next to cancer research. He's a Boston Red Sox fan. And I'll leave you with the last picture here. And this is after Dr. Hong threw out a ceremonial pitch, and that's our next guest, Dr. Howard Ko, and he's gloating like a little kid in the baseball field for the first time. So, anyway, it's been an honor.
Dr. Wan, thank you so very much for that very moving tribute. It's important to remember some of the luminaries, I think, and to remember the experiences of those of us who didn't have as large a Korean American community, and to be grateful, I think, for how far we've come and how much more we can build bridges. It is quite an honor to introduce the next speaker, Dr. Chin He, who is the Director for Healthcare Innovations Research and Evaluation Population Health at Columbia University Irving Medical Center. He is also a dear friend and colleague, a fellow gastroenterologist. And so without further ado, Dr. He.
Dr. Wan, I appreciate you providing us insight into the contributions of Dr. Wang Ki-hong, and I'm honored and privileged to speak at his memorial lecture today. And incoming President Kim, thank you for the kind introduction. Next slide. So I think my life journey may be familiar to many of you. Like Dr. Hong, my family immigrated from Korea to the US in the 1970s. And although I was only 5 years old, even as a young boy, I vividly remember the move. No, it wasn't quite like the the 3-week ship ride that my father took to the US as an international student in the 1950s, but it was on board a KAL 747 jet flight. But my transition from Korea to Korean American began on that flight because when I boarded the airplane cabin, I boarded with my shoes in my hand because I saw carpeting on the cabin floor. And I remember those aren't actually the flight attendants, but let's say they look like them, smiled, they squeezed my cheeks vigorously and told me to put my shoes back on, and hence my transition to Korean Americanism. Next slide. So since 2010, I've been fortunate to be part of the NCI's CISNET Modeling Consortium. And I've run the esophageal cancer group and more recently the gastric cancer group. And we do comparative modeling and we do statistical modeling and cost effectiveness studies. And that's to provide guidance for cancer screening and prevention for the country. So cancer control, that's the term used by the NCI, is a way at looking at cancer epidemiology from the bird's eye perspective. So to observe the national cancer landscape and identify trends, specifically the bad actors. And that the hope is to guide future resource allocation for countermeasures, such as interventions, preventive interventions, and also to guide research funding. So I'll start with an overview of population level cancer trends in the US and then Korea to get started. Next slide. So this is I'll walk you through this. I'm hoping that you had some coffee. This is a 2x2 figure of the leading 10 cancers in the US, and this is from the ACS website. The new cases or incident cancers are in the upper row, and the mortality in the lower row. So if we start with men in the upper left, the number one cancer in terms of numbers is prostate cancer, and there's expected to be about 250,000 cases. So this is by far the most common cancer in men. However, if you go down and look at the mortality, yes, it's number 2 by ranking, but the absolute number is under 35,000. So that's compared to the 250,000 cases. So this phenomena is called overdiagnosis. And the concern is that it leads to overtreatment, as many patients will be diagnosed but will not die from it. And so in response, this has led to the discontinuation of universal PSA screening in the US, as you're aware. So in contrast, if you look at pancreatic cancer, it's number 10 on the list of incidents, but because, number 10 on the list, and there's about 32,000 cases per year, but it's number 4 in terms of mortality, and there are 25,000 deaths. This is because pancreatic cancer, as we're aware, is very aggressive, and most patients with pancreatic cancer succumb to it. This is also known as the case fatality rate. So I think it's important from a cancer control perspective to look both at the incidence and mortality may be the overall more important number. So if we look at the right on the women's side, breast cancer is still the most common and second in terms of mortality. So other broad trends, lung cancer is always a very large and difficult cancer for both sexes, and number 1 in mortality for both men and women in the US. And colon cancer is consistent as it's number 3 in both incidence and mortality for both sexes. Just of note, I just want to point out on the women's side that uterine cancer is number 4 in incidence and number 6 in mortality. But I point this out because it disproportionately affects Black women and is what we call a cancer disparity issue. Next slide. So I know it's difficult to see, but I needed to get both of these on one screen. So these are cancer mortality trends starting in 1990, extending to 2018, with men, the mortality trends for men on the left and women on the right. So we can get an idea about future trends if we mentally just extend the line past 2018. So for both men and women, lung cancer, which is the dark blue, has the highest mortality rate. But the good news is that both are falling quickly. And similarly for the medium blue, which is colorectal cancer, so again, falling, which is good. This is probably attributable to smoking, and we like to take credit as gastroenterologists and screening colonoscopy. For both men and women, the only two cancers in the US that are rising in mortality rates are pancreas, which is hard to see, but it's in light blue. And the second is in light gray, and that's liver cancer. So that's something from a cancer control perspective that we definitely take note of. So let's move on to parallel figures in Korea. So similar to the US, the large or common cancers, lung is number 1 in men and number 4 in women in terms of incidence, and number 1 for both, just like the US in terms of mortality. So lung is always a big issue. Colon cancer similarly is number 3 and number 2 in mortality, so similar to the US as well. Now, differences between Korea and US trends is one is whereas gastric cancer, less common in the US, but it's still number 2 in men and number 5 in terms of incidence in Korea, although the mortality is dropping down to 4 and 7. I also want to note liver, which is much more common here in Korea, number 5 and 8, but the mortality is higher at numbers 2 and 4 for women. I'll show this in the next slide in trends, but thyroid cancer is number 2 in incidence in women, but doesn't even make the top 10 in mortality. And this is an even more extreme version of overdiagnosis, as I described for prostate cancer in men in the US. So next slide. So this is the Korean cancer trend figure, and it's laid out a little differently. The upper row is for men and women, and the lower row, the upper row are men, the lower row is women, and I'll focus on the mortality figures in the right column. The mortality is on the right, the incidence is on the left. So starting with the male mortality trends in the upper right, the prostate light gray is showing rising mortality. Stomach, which is blue, is decreasing in both men and women. This is both on the right. This is the mortality I'm talking about. And colorectal cancer has risen, but it's plateauing, has plateaued and is not coming down yet. And that's different than compared to the US. Now, if we focus on women in the lower panels, the pink is thyroid cancer. It's a very large spike. If you look in the lower left, that's thyroid cancer in women. And that's, again, an example of overdiagnosis. And this is related to screening that happened, and women have more thyroid nodules that were detected. But if you look at the mortality, you can't really see it, but it's close to 0. And the good news is that papillary thyroid cancer, almost nobody dies from it. So an example of overtesting and overdiagnosis. Next slide. So in summary, like cancer control perspective or bird's eye view, the similarities between the US and in Korea in terms of lung, colon cancer, and prostate in men and breast in women continue to be the dominant cancers. But in the US, for future projections, the 2 salient cancers are pancreas. And actually the projections are by 2013, or just 9 years from now, it will be the number 2 cancer killer in the US. Even though the incidence isn't that high. And then liver cancer mortality is also rising, largely in foreign-born immigrant populations. In Korea, similar large cancer trends, but stomach is more common but decreasing in mortality, so that's good news. And in future trends, liver cancer mortality is increasing. Colon cancer, unlike the US, the mortality is not decreasing. Next. So I'm going to transition here. I'm a practicing gastroenterologist, as Dr. Kim mentioned, and an endoscopist. So I'm going to shift a little bit to my area of expertise, colorectal and gastric cancer. And I think you'll understand why as it pertains to the Korean American experience. So this is on the picture on the right. I brought 2 GI fellows with me, and I spent a week with Dr. Jung at Asan Medical Center, observing gastric cancer screening and the large number of ESDs they do there. When Dr. Jung found out I had not had a screening upper endoscopy, he did one. He told me to come in, told me to lie down. That's me, unsedated. Just of note for us weak Americans, as we do upper endoscopies with anesthesia, it's really not that bad having it unsedated, especially if it's done by someone who's skilled. Next slide. So this is a classic study, and I understand it was done in Japanese immigrants in the 70s, but I think it has parallels to the Korean community. So if you look at the column on the left, this is stomach cancer, and the column on the right is colon cancer. And the top bar are rates in Japan for stomach cancer. And if you look at the first generation, that's the next bar, that's first generation immigrants. And then below that is second generation immigrants. So what we see is that with more time and successive generations in the US, the risks of gastric cancer start to approach American-born citizens or American-born individuals. So now on the flip side, if you look at colon cancer, it's the opposite. Japan has low rates of colon cancer, but as by successive generations, it starts to approximate American-born individuals. So what's going on here? The conclusion is simply that there's a change. This is largely environmental risk factors. And the diet probably has a large part of the explanation for this. It's a large part of the explanation. Next slide. So the US, if we look at the US population, almost a quarter, if you include second generation, are foreign born. And the projections are by 2050, almost 37% of the country will be foreign born. Next slide. And then this figure highlights the trend in where immigrants are coming from. The dark brown on top is decreasing European Canadian influx and increasing immigrants from Asia, Latin America, and Mexico. Next slide. So this goes back to my personal journey, perhaps many of you. So this is the food I was eating until the age of 5 in Korea. And then this is the transition from plant-based foods like kimchi, doenjang, and namul to a much higher fat and meat concentration diet. I believe this food transition is common to many Korean Americans. And now, because of globalization, I think that Koreans make the best fried chicken in the world, in my humble opinion, and may have parallels to other immigrants and then perhaps the Korean community in Korea. Next slide. So the question is, what can we do to lower a risk of colorectal and gastric cancer? So I'll do an overview of known risk factors for the two cancers and then ultimately focus a bit on diet. So we'll start with colon cancer. So we can broadly categorize cancer risk factors into two categories, those that are not modifiable and those that are. So for colon cancer, the unmodifiable risk factors include genetic syndromes and family history, being male, and diseases with chronic inflammation of the colon, such as inflammatory bowel disease. The modifiable risk factors for colon cancer are common to many, some other cancers, including smoking, as well as obesity and alcohol intake. But then there's a lot of dietary risk factors. Red meat and low vegetable fruit consumption increase risk, whereas high fiber fish, dairy, nuts can reduce colon cancer risk. Now, diet can be a little bit tricky. The data is difficult to tease out epidemiologically because, for example, the benefit of high fiber may really be a result of eating less red meat. So we do need to be careful about changing behavior too much from epidemiologic data. Next slide. Oh, sorry, I missed that last transition. So that, okay, next slide. So moving on to gastric cancer. So similarly, family history and genetic syndromes, being male, chronic diseases that lead to chronic inflammation in the stomach, like autoimmune gastritis and pernicious anemia. These may be not modifiable, but the greatest modifiable risk factor is Helicobacter pylori infection. And the World Health Organization has accordingly categorized it as a class 1 carcinogen and estimated that 89% of gastric cancers are probably associated with this infection. So smoking is another risk factor. Obesity is mainly a risk factor for the gastric cancers of the upper stomach or cardia, which behaves more like esophageal adenocarcinoma. It's less common in East Asians. So this table, the font's a little small, but the table has dietary risk factors and the table has dietary risk factors and with things on the left column representing foods that decrease gastric cancer risk, and those on the right with increasing. The lower level also represents less clinical evidence to support this. So if you look at the upper left, there's good evidence that non-starchy non-starchy vegetables, allium vegetables like garlic, onions, and scallions, which are a mainstay of Korean food, can be associated with reducing risk. But if you look on the upper right, for those things that increase risk, the most salient risk factor is salt. Smoked foods, processed meats are not as conclusive. And as I mentioned, the diet sometimes is hard to tease out because of confounding. So for example, selenium-rich foods includes fish and seafood, but also high saturated fat content meat. So chili is controversial, especially for us Korean. The ingredient is capsaicin. And in epidemiologic studies, it has been associated with gastric cancer and gallbladder cancer in particular. But capsaicin could also be an antioxidant, and some propose that it may be anti-cancerous. So again, although there is some epidemiologic evidence that suggests it may be associated with gastric cancer, I think the jury's out a little bit on that one. Next slide. So I'm going to move forward quickly, but this is salt is probably the biggest risk factor for gastric cancer. So this is there's been a public health effort in Korea to reduce the salt consumption, and this table shows the primary suspects here. And if you look at the far left, that's kimchi. Turns out kimchi provides up to a quarter of the salt content in the Korean diet. So we need to do something about that. Next, this is a modeling study we did in the US, a thought experiment where we said everyone in the US would go on the DASH diet, which is a research diet that's for hypertension control. It requires reducing sodium levels about 30 to 50% from standard US diet. And I won't get into all the details for time, but we found that hypothetically, if everyone in the US lowered their sodium content by that much, that 20 to 25% of gastric cancer incidence and mortality could be reduced. Next. So I will try to pick up a little speed. So is kimchi good or bad for you? Kimchi is such a large part of Korean culture and identity. And the picture on the left, that's not Korea or Seoul, that's Uzbekistan, where, as many of you know, that a Korean community thrived under the Soviet Empire, the Soviet bloc, and they still eat kimchi, such a large part of our identity. So as you know, salt in the fermentation process was before refrigeration after harvest to maintain food for the winter. So I think salt's been central to Korean civilization and Korean culture, but with refrigeration, it may be less important. So it's difficult, but I think we need to reduce salt, although it's hard because salt makes food taste so good. Next. So very briefly, I just wanted to touch on probiotics because it turns out that kimchi and doenjang are really high, one of the highest loads of good bacteria probiotic. It turns out that it's also really good as a sauerkraut because it also is a prebiotic. That's the food that feeds the good bacteria. And so those we call symbiotics. So the health benefits, I think there's evidence that it prevents infection. There's stool transplant studies in C. diff and gut inflammation. The initial yogurt studies found less vaginal yeast infection in women with yogurt. So I think there are benefits. The difficulty is that we need to balance some of these suggestive evidence and animal studies that with the potential harms of kimchi and doenjang because of the salt, which is a high risk factor. Next. So I think I'm going to largely skip this for time, but this is also in homage to Dr. Hong, who did some of the early biomarker work for targeted lung cancer treatment at MD Anderson. But one of the things I will highlight in cancer biomarker panels is there's a company called Grail, and they're making cell-free DNA panels for up to 50 cancers that you can send them a tube of blood, and they claim a pretty high specificity, so less worry about false positives. I think this could be helpful in the future. I'm a little hesitant to recommend it now because I'm concerned about overdiagnosis and false positives, but there's a lot coming, and precision medicine, precision cancer is definitely going to be transformative in the next few years. Next. So in summary, sorry, I'm running a little over. I went over cancer trends, just to highlight pancreas and liver are on the rise in the US. In Korea, it's colon cancer still is still rising in women and plateauing in men, and liver cancer is increasing as well. We talked a lot about colon cancer. We talked then about colon and gastric cancer, particularly from a Korean American perspective, and the modifiable risk factors. And overall, I'd say, I think we know the answers: don't smoke, drink less, eat less red meat, and eat more vegetables and fruits. But I will say, as a Korean American who enjoys Korean food, kimchi and doenjang may have many health benefits, but I think we need to lower the salt. And if you really want to be careful, try to eat less spicy kimchi, although I think the jury's out on that. Next. So I will end with that, but I do, as an endoscopist, want to say that gastric and colon cancer screening works, and I believe in endoscopy. Next. And one more. That's my high school age daughter and me, and we did a ride for Team Stomach to raise funds for gastric cancer research. So sorry I ran a little over, but thank you for your attention.
Thank you so much, Dr. He. There is actually a question here in the chat, and perhaps in the interest of time, we'll limit it to this one question. So the question is, my patients have asked if all Koreans should be empirically treated for H. pylori. What should I tell them?
No, I would say no. I think a urea breath test is the most sensitive test for diagnosis, a diagnostic test. The other way to do it, if you really want to be aggressive in someone who's has like many risk factors, is to do a serology test. Now, the problem with the serology is that it could be a prior infection and no longer active infection, and treat if the serology test, and therefore it's easier to do than a breath test. So I would be more agreeable to that strategy, but just treating every Korean, I don't agree with that. And also, with the probiotic revolution, it's the concept that if you give antibiotic system, and antibiotics are dangerous because not only are you killing the weeds on the lawn, that's my analogy, you're killing all the grass, and bad bugs might grow back, or more weeds might go back. So I think the probiotic revolution has made us more wary of antibiotic treatment.
Thanks so much, Dr. He. And thank you also for your insights into what the future of cancer management might look like. In the interest of time, I think we're going to close this session, but I'd like to thank again Dr. He so much for giving that illuminating lecture, and pleased to ask all of our attendees to ensure that they come back after a brief break at 9:55 or 7:55 if you're in the U.S. Eastern Standard Time for our keynote address delivered by Dr. Howard Koh. Thank you so much. questions basically just come up here on the YouTube chat. The questions will just come up here.
Okay.
Okay?
And then I just agree that's okay.
Yeah, and I'll take a look also.
Okay, what am I doing? So we're gonna
Yeah,
start
so
next
you're
session.
gonna get started, yeah.
And I'm gonna speak here? I'm gonna speak.
I think you're over here because you're
Okay.
I mean, it's just, you know, the keynote address.
Okay.
Okay, you all set?
Okay. We're going to move on with our keynote address. Good morning. I have the privilege of introducing Dr. Howard K. Koh. This is certainly not an easy task because all the numerous accomplishments, it's kind of hard to put everything in a few minutes. But Dr. Howard Koh is the Harvey V. Feinberg Professor of Practice of Public Health Leadership at the Harvard T.H. Chan School of Public Health and Harvard Kennedy School. He has advanced leadership education and training at the Harvard T.H. Chan School of Public Health, as well as across Harvard University. From 2009 to 2014, Dr. Koh served as the 14th Assistant Secretary for Health and Human Service, where he was nominated by then President Barack Obama. During that time, he oversaw 12 core public health offices, including the Office of Surgeon General and the U.S. Public Health Service Commission Corps. He promoted disease prevention and public health dimensions of the Affordable Care Act and advanced outreach to enroll underserved and minority population into the health insurance coverage. He helped to coordinate the federal response during the 2009 H1N1 pandemic and was the primary architect of the landmark HHS Strategic Plan for Tobacco Control and Health Disparities. Dr. Koh also led interdisciplinary implementation of the National HIV and AIDS Strategy, as well as initiatives in nutrition and physical activity, cancer control, adult immunization, and women and adolescent health. In other words, Dr. Koh tackled on virtually any project which he believed could benefit the public, and is simply an unwavering public servant. In his academic career, Dr. Koh has been principal investigator for over 25 million research grant activities. He has published more than 300 articles in the medical and public health literature. From 1997 to 2003, Dr. Koh served as a commissioner of public health for the Commonwealth of Massachusetts. As a commissioner, he led the Massachusetts Department of Public Health, which included a wide range of health services, hospitals, and over 3,000 health professionals. And his passion was over tobacco control. Dr. Koh graduated from Yale College, where he was also president of the Yale Glee Club and attended Yale University School of Medicine. He completed his postgraduate training at Boston City Hospital and Massachusetts General Hospital, where he has earned 4 board certification in the field of internal medicine, hematology, medical oncology, and dermatology, as well as Master of Public Health from the Boston University. Dr. Koh has earned over 70 awards and honors in interdisciplinary accomplishments in medicine and public health. He's a member of the National Academy of Medicine, multiple advisory boards, and so on. Dr. Koh was also named as one of the most influential person in the fight against tobacco in the last 25 years. He also was named to the K100, which is the 100 leading Korean Americans in the first century of Korean immigration to the United States. He has been recognized by the Modern Healthcare as one of the country's top 100 most influential people in healthcare, as well as the top 25 minority executives in healthcare. And in 2019, HHS established the annual Dr. Howard Koh Award for Excellence in Leadership, sponsored by the Federal Asian American Council. He also has a distinct ceremony, as I show in the picture, that throwing out 2 pitches at the National Park in Washington, D.C. on behalf of HSS, and then also at Fenway Park for recognition of his work. Dr. Koh and his wife, Dr. Claudia Arick, have 3 adult children and 3 granddaughters. And on a personal note, I just want to say I first met Dr. Koh by email back in 2014. And from day one, he could not have been more gracious, always willing to help and give meaningful advice. And Dr. Ko actually traveled down to New York City where we met in person and spent hours discussing with me a range of topics, especially pertaining to the Korean Americans. And one of them being health disparities in Asian American, which I know he's very passionate about. And Dr. Ko is a supporter and believes in the mission of KAMA. I'm certain that he believes that this organization could serve as a national platform to address many issues pertaining to the KA, and it is our obligation and duty to do that. KAMA, if you think about it, has been around for 46 years, which is extremely long time, and it's sustained only by spirit of volunteerism and service. And we represent Korean American heritage. It also represents the struggles and challenges faced by the Korean Americans who immigrated to this country. And it represents a story about our parents and families, and I don't think there's anyone out there who understands this better than Dr. Howard Ko. Dr. Ko came to speak in the 2017 Washington DC Convention in DC, and that was probably one of the, was the most memorable moment during my almost 2 decades of involvement in KAMA. He talked very emotionally about his father and mother, who are his role models, and growing up as a Korean American immigrant along with a sibling. And there were many in that room, including myself, that tried to hold back tears because his speech was simply so moving. Personally, Dr. Ko has been my role model, and he's the reason for my service to KAMA. He has encouraged me at every step and has given me the clarity and better understanding what it means to serve. His words of encouragement to me only a couple months ago during one of the most tumultuous times at KAMA could not have come at a better time. It has helped steer this organization in the right direction. And he's very special. And if you have been fortunate, as I have known him, you could just feel this palpitation to serve in the room. Dr. Ko, you have been an inspiration for us at KAMA, and you and your entire family, including your brother Harold, have been a benchmark for public service and represent the very best of Korean American. Your family's work through the public offices in government and in foundation are truly remarkable. And I want to just make one final comment before asking Dr. Ko to come up to the podium. And there's a proverb in Korean custom that roughly translates into something like this, and basically says a success of a person belongs to a parent because it is a reflection of them and what they were taught. And I agree with this. And if Dr. Hee-sung Ko, if you happen to be logged in and watching, thank you very much. Now I have the distinct pleasure of introducing Dr. Howard Ko, our keynote speaker. Thank you very much.
Thank you so much, Dr. Wan, and I want to thank you for that very warm introduction. I have such wonderful memories of working with you over the years and seeing your incredible dedication to KAMA and to the mission of understanding between Korea and US and global health. And every time I have interacted with you, I have felt your passion and commitment. So to be able to speak at this conference means so much to me, and I'm very proud of you, Dr. Wan, Dr. Choi, the president, and the growth of KAMA. I wish I could be in Seoul with all of you, but I want to express my gratitude to the organizing committee for inviting me for this very important 3 days. Your words were very personal, and I always feel that our work is quite personal too. And my Korean American background has made me who I am, has given me the values and the motivation and the drive to do the work I do. And today I was asked to talk about public health and diversity, particularly as it pertains to Korean Americans. So this will be a quick overview on a number of public health issues in the United States related to Asian Americans, Native Hawaiians, and Pacific Islanders, with particular attention to Korean Americans during this critical time of COVID. And if I can say, I've heard a number of the previous speakers. Dr. Wan, your reference to the late Dr. Wan Ki-hong, I found very moving. Dr. Hong was a mentor to me. So I think about him and my parents and all the people who came from Korea to the United States to find the American dream and help build a better and healthier world. So if you don't mind, I'm going to make this quite a personal as well as professional presentation going forward. So first slide, please. So I have to start with my family, and over on the left is a picture of my parents, Kwang Lim Ko and Haesung Chun Ko, when they were young Korean Americans in our country. I cannot imagine the courage it took for them to come to the US back then and start a family. My beloved dad passed away some 30 years ago. I still miss him every day, think about his drive and passion. My mom is now 92 years old, young, and there's a picture of her on the lower left, and I think she is watching. Mom, we're very, very proud of you, and the sacrifice that you and Dad made to come to this country has been worth it. I just want to tell you that. And then over on the right is my immediate family, and I just want to extend my deep gratitude to them because they are very proud of our family's Korean American heritage. My wife, Dr. Claudia Arag, is a practicing ophthalmologist and eye surgeon. My son, Steve, is an international lawyer and a professor at Boston College Law School. My daughter, Katie, is an MD psychiatrist, is a street psychiatrist for Boston Healthcare for the Homeless. And my son, Dan, is a businessman and a public servant. He is currently Chief of Staff to the Secretary of Labor in the Biden administration. And my family all talks about and feels the impact of our Korean American heritage literally every day because it's part of who we are and why we do what we do. Next slide. So all those themes really motivated me when I became the Assistant Secretary for Health in the Obama administration in 2009. Now, as Dr. Won mentioned, I previously had the privilege of serving as Massachusetts Commissioner of Public Health in our state from 1997 to 2003. So I'm a physician who's now spent over 11 years of my career in public leadership positions in government at the state and federal level. I never planned it that way, but that's the way it's turned out. And I can just tell you that if you have a medical background, but then proceed into public health, it just changes your life. It gives you a broad perspective on populations and risk, and you ask yourself fundamental questions about how to keep populations as healthy as possible. These are key questions, of course, now during COVID. And then to work in government with dedicated public servants is just an indescribable privilege. So on this slide, I just want to acknowledge the leadership of Secretary Kathleen Sebelius. I had the privilege of working under her, and also Secretary Sylvia Burwell briefly, as the Affordable Care Act was adopted and implemented. Of course, had the privilege of working with the president and meeting the then Vice President, now President Biden. On the lower right is a picture of me with my cherished colleague, Dr. Tony Fauci. Tony is absolutely a historic and legendary figure, and I enjoyed hearing his comments to come out last night. And then I've also, in my public career, had the opportunity to work with other leaders of Korean background. Here's a picture of me doing an interview with former UN Secretary General Ban Ki-moon, who is a very respected global leader. And on the bottom left is a picture that my family likes a lot, if I can say. This is a fall of 2009 when President Obama reinvigorated the White House initiative on Asian Americans and Pacific Islanders. He had his top Asian American appointees stand behind him in the East Room of the White House. So standing behind the president in the blue tie is me. And to my immediate left in the pink tie is my brother, Harold Ko, who at the time was the top lawyer in the State Department under Secretary Clinton. So needless to say, my mother likes this picture a lot. We were very proud to represent the Korean American community and the Asian American community in the Obama administration at that time. Next slide. So in my work at the Department of Health and Human Services as Assistant Secretary for Health, I spent a lot of time on minority health, on health disparities, on health equity. These are themes that have been important to me personally and professionally for reasons you all understand. In 2011, the Secretary, Kathleen Sebelius, asked that our HHS action plan to reduce racial and ethnic health disparities get updated. So I had the privilege of overseeing that action plan. and then publishing that report. Article to the right is a headline of an article that came out in Health Affairs summarizing the action plan based on the passage of the Affordable Care Act. Among other things, it created new dedicated offices of minority health in multiple parts of HHS. And so I always had the particular issues of Asian Americans, Native Hawaiians, Pacific Islanders, and also especially Korean Americans in mind as I did that work. Then if I can also say, as Assistant Secretary, I oversaw Healthy People. Many of you familiar with American public health know that Healthy People is a roadmap and compass for the U.S., for the country of the U.S., that's updated every 10 years. And in Healthy People 2020, which I oversaw, and then updated in Healthy People 2030, just released, the mission of eliminating health disparities was one that we made a major priority. Next slide. So how does this all relate to the Asian American and Native Hawaiian Pacific Islander population, AANHPI population? One of the things that's very gratifying about giving a talk like this was when I was a much younger physician and researcher, I looked everywhere for data and research and articles about Asian American health and even Korean American health, and back then found next to nothing. So over the years, we're seeing much more growth of our population and therefore much more interest in the health of our population. You may know that the AANHPI population in the US, Asian Americans, Native Hawaiians, and Pacific Islanders, now amounts to some 23 million people. We are the fastest growing racial group in the US, projected to double by 2060. Next slide. And we have a broad array of characteristics that underscores the fact that we are highly heterogeneous as a group. So 6 subpopulations have over 1 million people each in the US, as you can see here, Chinese, Japanese, and others. Korean Americans are about 2 million, as you can see on the right. But the AANHPI population makes up some 50 ethnicities, 100 languages, 2/3 of us are foreign born. And so part of the challenge of talking about disparities and health equity and public health in our country, in the US right now, is the term Asian American is way too broad. I often like to say that the term Asian American is as useful as the term European American. So we need better data, we need better attention, and we need to identify the challenges that are affecting our population at a time like this. Next slide. And just to give you an example of the heterogeneity of the AANHPI population, here is a display of how the various subgroups rank according to education on the x-axis and income on the y-axis. And you can see that some groups, like the Indian American subgroups, do very well on both of those dimensions, but all the way down to the lower left, for example, the Pacific Islander populations, the Burmese American populations have much lower levels of attainment. The Korean Americans are somewhere in the middle here. So again, when you talk about the Asian American, Native Hawaiian, Pacific Islander community, this is a broad heterogeneous group, and we need better data in all of our subpopulations. Next slide. So this led to efforts to raise awareness, particularly in 2020 and 21 through COVID, and particularly after the George Floyd murder, with so much attention to minorities and disparities and inequities in the United States. So in the August 17th issue of JAMA, I and my dear colleagues Juliet Choi and Jeff Caballero co-wrote an article called Toward Healing and Health Equity for Asian Americans, Native Hawaiians, and Pacific Islanders, the August 17th, 2021 issue. And in it, we try to point out some major things that I'm sure this audience knows very well because we live it every day, and that the AANHPI population is often invisible or misunderstood. We have contributed to the nation's social fabric for centuries, but we're still regularly treated as outsiders, or them rather than us, and even as foreigners in our own country, and that's very, very difficult. We have to stress that the the model minority is a myth because our group is so heterogeneous, as I showed you on the previous slide. And then when you get into health and Asian Americans, it gets even more complicated. There's no doubt that even though we have a fair number of US physicians and surgeons of Asian American, Native Hawaiian, Pacific Islander background, again, that representation varies by subgroup. And also, we are not represented in leadership positions the way we should. And I'll be saying more about that in just a second. Next slide, please. So you all know that we've had some very disturbing national hate incidents against the Asian American, Native Hawaiian, Pacific Islander population last year and this year through COVID and through the frank xenophobia that we have heard on the media all the time. This came to light particularly this past March in Atlanta when a young man shot and killed 8 people in Atlanta spas. 6 were women of Asian descent, 4 were of Korean origin. So that certainly caught all of our attention, as you can see from the headlines and pictures over on the right. And this persists up to the present time. I'm sure all of you watching the Tokyo Olympics this past summer were very struck by the fact that Suni Lee did such a beautiful job as a US gymnast. She was the first Hmong American to represent the US in the Olympics and win a gold medal. But just last month, she reported that she was attacked with pepper spray by a group of people in a car passing by yelling racial slurs. And so in this era, there has been a new website and database called Stop AAPI Hate that's been established to track the number of hate incidents and to see how much of this is related to frank xenophobia through COVID. It's very disturbing when people are assaulted and it's accompanied by the sentiment, go back to where you came from. And I often hear that and I think, well, what if you came from the United States of America? What do you do then? So this is a time when I know a lot of people of AA and NHPI background are raising their voice saying we are not an invisible group and we need to be respected for our own story and for the journeys that got us here in the first place. Next slide. Some of these crimes, by the way, affect AA and NHPI health professionals. So here's the irony: in the midst of COVID, we have dedicated doctors and nurses and health professionals at the bedside trying to save people's lives, and they are exhausted. But in this one case shown here, a Mount Sinai medical student was going to work, was assaulted by a man who was yelling racial slurs. So she subsequently organized this rally with over 1,000 health professionals in white coats, bringing attention to this issue, saying that this should not be tolerated. So it's great to see the younger Asian American, Native Hawaiian, Pacific Islander health professionals being empowered like this, raising their voice, raising attention to the issues that affect all of us. Next slide. So I have mentioned briefly, and now I'll reemphasize that we need more leadership of NHPI health professionals in medicine. On the bottom right is another article that came out in that same issue of JAMA on August 17th. This one first authored by Dr. Augustine Choi, the Dean of Cornell Medical College, and I believe the husband of Dr. Mary Choi, so that's quite a family. And so we need more leaders like that in academic medicine and in Korean American medical circles. There is a National Council of Asian Pacific Islander Physicians led by my colleague, Dr. Winston Wong. And we know that a lower proportion of Asian American faculty members, both men and women, advance to the level of full professor or department chair, and we need to change that. Next slide. And then in time of COVID, I have looked long and hard for peer-reviewed literature about how COVID-19 has affected the AA-NHPI population, and there are very, very few of them. Here's one that just came out in the Journal of Internal Medicine in August, out of Dr. Tung Nguyen's shop in San Francisco. And it turns out that I became aware of this because the first author, Brandon Yan, is a new student of mine at the Harvard Chan School of Public Health. He heard me talk about COVID and came up and said, Dr. Ko, do you know that we just published something on how COVID affects Asian American populations? I said, oh my goodness, please send that to me. I've been looking for that. So you may want to look at this article because this very early data shows that perhaps the impact on Asian American, Native Hawaiian, Pacific Islander populations is higher than we might expect with excess all-cause mortality, higher case fatality rates, and a higher likelihood of hospitalization compared to other groups. And we have to dig down deep and find out why this is the case. Is it because Asian Americans are more reluctant to seek care in a time like this? They have less familiarity with navigating the health system in tough times. Many of our family members are foreign born and don't speak English as their first language. Does that come into play in a time of a crisis and a pandemic? These are all issues that we need to sort out. The impact on mental health, by the way, is extraordinary, and we need to pay attention to that too. Next slide. So in short, we have a profoundly heterogeneous population. We are not a monolithic group. And as I mentioned in the past, when I look for data, and as we all look for data on AA and HPI health issues, we found them to be incomplete, misclassified, aggregated, or simply absent. And too often we hear there's no data, and the assumption is with no data, there's no problem, when that is the furthest thing from the truth. Next slide. So this is one of the reasons why it was profoundly gratifying to me as the Assistant Secretary for Health when the Affordable Care Act was passed, not only because of the health insurance coverage implications, I'll be saying more about that in a second, but here's this seemingly obscure part of the ACA, Section 4302, that updated the data collection standards. Too many times when we do research in the United States, the race options are black, white, other, if it's asked at all. Sometimes it's black, white, Asian, other. But because of Section 4302, it required that all HHS-sponsored health surveys involving self-reported information had to include detail relevant to Asian Americans and Pacific Islander that included multiple subgroups like Chinese American, Japanese American, and Korean American as an option, as I point out in red there. So I was absolutely delighted to see that and did a lot of education and speaking and outreach about updated data collection standards, because if we can track issues related to Korean Americans through surveys and other public health studies and do analyses and reports, we can better serve our population. So over on the left is an article we published in the annual reviews of public health, educating professionals about that very important theme. Next slide. And then many of you may know that a lot of our US health data comes from this classic effort called the NHANES study, National Health and Nutrition Examination Survey, where Americans have their health and nutritional status examined in these trailers that travel around the country. So I got escorted through a tour of one of these trailers, as you can see here, to see how they measure people's height and weight, and they draw blood and do dietary questionnaires. And then I was delighted that during my time, NHANES began to oversample Asian Americans for the first time. So now when you look at NHANES data, there are detailed pieces of information about Asian American health, and now more on Korean American health, when before the response was always, oh, we don't have enough data on you, there are too few of you. Well, if you oversample, you can get that information. And so this is one of the efforts that we have launched at the national level over the last 10 years, which is very gratifying to see. Next slide. And then there are a number of health disparities that I know have been already discussed at this conference. Cardiovascular mortality, hepatitis B is a major problem for the world, for Asia, and then in the United States for AA and HPI populations. So 1 in 12 Asian Americans is Hep B positive, but the awareness of this is low. We just heard Dr. Chin He talk about cancer rates in Korea versus the United States, special attention to stomach cancer and liver cancer. Some of that liver cancer incidence and mortality related to hepatitis B. And then many of you may know, and I think Dr. Wan mentioned that it was tobacco control that got me into public health from before when I was a practicing clinician. Because when I saw people using tobacco, being addicted to tobacco and not being able to stop, it really made me start to think about how can we go broader in terms of preventing tobacco addiction and saving lives and reducing lung cancer risk as well as esophageal and many other cancers related to tobacco use. Korean Americans are at special risk for this. In the United States, some estimates are that up to a third or more of Korean American men are active cigarette smokers. And actually, this interest led me to one trip to Korea, invited by my dear friend, Dr. Sung-il Cho from Seoul National University. I think he spoke last night, and he's doing tremendous work in Korea on tobacco control, and I respect him. We have a lot of work to do because the tobacco industry has targeted Asian men for far, far too long, making it part of the business culture. And we got to reverse that trend because far too many people are dying preventable deaths, especially in places like Asia and Korea. Next slide. So here's an example of how my time in public service gave me an opportunity to do educational outreach to Asian American populations. So when I was state health commissioner, this advertising firm came to me and said, Dr. Ko, I know you're interested in tobacco control. Let's put your face on Asian language posters. So there I am on the left one with a message about stopping smoking in Korean, but they put my face on other ones with other languages that I know nothing about, by the way. But so I chuckled about it, and they chuckled too. But they said, well, Dr. Ko, you're Korean American, you're Asian American, you know, we should be able to use your image here to help promote public health. So I was delighted to do that. And then another example of where I felt very proud to do that was on hepatitis, because this is a great example of how the National Academy of Medicine and the Health and Human Services Department work together on viral hepatitis. On the top right are two major studies from the National Academy of Medicine, formerly the Institute of Medicine, about the need to tackle chronic hepatitis as a national and global effort. And when that study was done, Dr. Sam So on the bottom left from Stanford, who I think Sam is a Chinese American, came to me and said, Howard, you're the assistant secretary. Too often these reports are made and they sit on a shelf. But if you and HHS take this over and come out with a national strategy and start implementing it, all our efforts can be turned into action to help people. So I turned to my HHS colleagues. We talked about it very quickly. We decided it was a great idea. We worked hard. I really want to thank Rosie Henson, Ron Valdesari, and John Ward, also pictured on the lower left. And we put out a viral hepatitis plan in 2012, I believe, for the first time. It's now been updated 2 or 3 times as part of the national strategy for HHS. And a lot of it is outreach and education for populations who don't know they're seropositive for Hep B or Hep C. So next slide. So part of that outreach for Asian American populations was posters in English, Chinese, Korean, and Vietnamese, public service announcements. I did a lot of public speaking to Asian American and Korean American communities around the United States, and they put me on another poster here. Next slide. And multiple more in other Asian languages too. So I chuckle at this when I see it, but I'm also very happy and proud that I could perhaps be an image that would help promote health for the Asian American community in the United States, and particularly the Korean American community. And then there are other issues like gastric cancer. Dr. Herr just mentioned this in the previous talk. And look at the relatively high crude incidence of gastric cancer in Korean Americans compared to those of other backgrounds. Several years ago, Dr. Ju-Ha Hwang, a Korean American gastroenterologist from Stanford, just called me up out of the blue. And he said, Dr. Ko, I want to start looking into programs to possibly improve early detection of gastric cancer in the United States. They're starting to do that in Korea and Japan. Why can't we do that and target Korean American and other Asian American populations? And so I said, okay, I think that's a good idea. Let me try to help you. So he convened a summit at Stanford right before COVID last year. That's where I met Dr. Herr for the first time. Actually, it was absolutely fascinating. There's a lot of fascinating studies to review. He had colleagues from Korea and Japan fly over and report on their efforts for screening and also elimination of H. pylori in those countries. And we have another summit that Dr. Hwang has organized this coming March, and I hope I'll be able to go out to California again and to see where progress has gone in this regard. Next slide. So let me comment quickly now on the status of the Affordable Care Act, because this was the defining theme through my time in the Obama administration, and we have all lived through this in the United States. Now in Korea, the health insurance system is so much stronger and the health insurance coverage rates are so much higher. But in the US, it's been a patchwork. And so the ACA implementation has been a very difficult ride after it was signed into law by the president on March 23rd, 2010. This past summer, the most recent Supreme Court case was struck down. So we're now hoping that people will leave the Affordable Care Act alone and people can enjoy the opportunity to improve their health insurance coverage. Right now, there are 12 states in orange that have not expanded Medicaid as of yet. And we hope more of those states do in the future because it's very important to improve health access and then health outcomes. Next slide. But one major theme through all of this has been the health disparities of insurance coverage by race and ethnicity. So many of you may know that communities of color in the US have lower health insurance rates than whites. And so, you know, I lived through this time and worked hard through this time, and then came back to Harvard, and I was working very closely with a brilliant Harvard Chan public health student, a physician of Korean descent, actually, Dr. John Park. He was my research assistant. And I asked him to do a literature search on health insurance coverage in Asian Americans through the Affordable Care Act. And he came back to me and he said, Dr. Ko, no one's ever published anything on this. I said, what? After all these years, and I got sort of embarrassed. I thought, okay, are the Asian American groups being overlooked yet again? So we did the study led by John, and I want to thank my co-authors here, Sarah Humble, Graham Kolditz, Arnie Epstein, Ben Summers. And this is a little graph from JAMA Internal Medicine, where if you see in 2009, in the top in light blue is the health insurance coverage rates in whites. Below it in darker blue is the rate of Asian Americans, Native Hawaiians, and Pacific Islanders. There is a gap. And then lower on is the Black rate and the Hispanic American rate. But if you can see that over time, over the years, especially after 2014, when the Medicaid expansion began, the gap narrowed and then absolutely disappeared. So that by 2016, there was no gap in health insurance coverage among whites and Asian American populations. So we were thrilled to see this and publish this in JAMA Internal Medicine. Next slide. But since I've talked to you a lot that we have to have more specific micro data about populations, our next question was, well, what about all the Asian American, Native Hawaiian, Pacific Islanders subgroups? Did they all benefit? So we did a follow-up study, published this in Health Affairs. Next slide. And I'm very proud to say that all the Asian American, Native Hawaiian, Pacific Islander groups improved in their health insurance coverage pre and post ACA. And this has particular relevance to Korean Americans, as you can see in red over on the right. Many of you may know that Korean Americans have traditionally had the highest uninsured rate of any Asian American group. There's still debate about exactly why. Many conjecture that it's because so many Korean Americans are small business owners. I know a number of my uncles have been, and I'm not sure they ever had health insurance when they were running their small businesses. But you can see in the before and after, there's a major drop in uninsurance in Korean Americans here, as we also see in all the other subgroups. So that was something we were very proud of. And you may ask, how did this happen? I fully give credit to the advocates in the country who did outreach in multiple languages, worked with navigators and assisters, signed people up for insurance coverage through Medicaid and on the exchanges. And too many times we hear, oh, you can't do good work in public health in Asian American populations. It's too complex and too many languages. Well, in my view, it's these advocates that made it happen. And I just want to thank them. I'm going to mention some of them at the end of this talk. Next slide. So as I near the end of this talk, I do want to say that it's been very exciting to follow the work of the White House. Under President Clinton, a White House initiative on Asian Americans and Pacific Islanders was established, and that's gone through every successive president. When I served, President Obama was very active in working with this initiative. I did show the picture where he signed the update of the initiative into law in the East Room of the White House in 2009. On the bottom left is a meeting he attended of our initiative and commission. And so now under President Biden, he has resurrected this initiative with Crystal Ka'ai, the executive director. She's pictured on the upper right. And there are some early goals of the initiative to look for better data for Asian Americans, to directly address Asian American bias, also try to improve language access for so many people who are struggling with limited English proficiency. And then over on the bottom right, this was a major step forward for Asian American, Native Hawaiian, public Pacific Islander health, when you see that President Biden several months ago signed the COVID Hate Crimes Act, saying that he wanted more tracking of hate crimes, more action to bring respect to the Asian American, Native Hawaiian, Pacific Islander community, and most importantly, to do prevention. So standing behind the president, of course, is the vice president, who is, of course, of Asian American background, Senator Duckworth, who's seated, Senator Hirano from Hawaii, Congresswoman Judy Chu of California, Congresswoman Grace Meng, Senator Blumenthal. These are all leaders I've had the privilege of meeting, and I want to extend my thanks to them on behalf of our community. Next slide. So this can't be done unless we have national collaborations, and I just want to acknowledge many of the heroic figures in our country who are working together. The Asian Pacific Islander American Health Forum, with my dear friend Juliet Choi, who's the Chief Executive Officer. She's Korean American and a co-author for me on the JAMA piece I referenced. The third co-author in that piece was Jeff Caballero, who's the next picture down, who's the head of APCHO, the Association of Asian Pacific Community Health Organizations. These are really heroic healthcare providers taking care of all of our families, whether we're high income, low income, or whatever. And Jeff and Juliet in particular have been dear friends for a long time, and I love and respect them both. I think I mentioned Dr. Winston Wong, the National Council of Asian Pacific Islander Physicians. I want to again thank Kama and Dr. Choi and Dr. Wan. And then I also want to give a shout out to my dear friend, Dr. Karen Kim, also Korean American, who has heroically led a new, relatively new Center for Asian Health Equity at the University of Chicago. Here's one of my last slides. I was tickled to see that on Thanksgiving, Sesame Street introduced Ji Young, the first Asian American and the first Korean American Muppet. So this is a 7-year-old Korean American with a passion for rocking out on electric guitar and skateboarding. And she talks about her love of Korean food, if you ever go on Google and try to see this. And apparently the creators of Sesame Street said, we got to think more about talking about diversity in our country, especially through COVID, with all the COVID-related xenophobia and in the wake of George Floyd's death. So we are making progress in our country to embrace the diversity of our nation. And I think we're making progress in trying to build ties with our country and Korea and other nations around the world. Last slide. So here's a slide I show in just about every talk I give. This is a quote from the World Health Organization: "The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being." I think about this a lot through COVID because we all deserve the highest attainable standard of health, but that's being threatened by COVID and many other factors, and the fact that our healthcare system and public health system is not what it should be. So I'm hoping through conferences like this and other efforts, we can make it all stronger going forward so we can build public health and the sense of health equity for all people in our country, for Asian Americans, and particularly for Korean Americans. Thank you so much for your time and attention.
Okay, we have one question, and Dr. Ko. The question is from Dr. Michelle Kim. She's actually incoming 2022 KAMA president. And the question reads, as members and leaders in KAMA, what do you think our organization can do to overcome these many challenges in the Korean American community? And second, what are the opportunities that we need to leverage?
Well, first again, Dr. Wan, I just want to thank you. You really have persevered through thick and thin, and I think the strength of this conference, what I've seen so far, has been so impressive. It is a indicator of the growth of CAMA and this organization. As I mentioned now multiple times, I think this is a very important year to be pretty public about the issues facing our community, the Korean American and Asian American, Native Hawaiian, Pacific Islander community. I think the more we explicitly connect with all those organizations I showed on the previous slide, if I can say particularly the Asian American Health Forum and Julia Choi is a group that I respect a lot. I'm delighted to see the former president of the AMA who opened up yesterday and she may be speaking again, Dr. Bailey, but so being close to the organizations around the country that are involved in medicine and public health and stressing that we as Korean Americans can make a contribution and work closely with them at a time like this is very important.
Thank you. Okay, I believe that concludes the session. Okay, Doctor, thank you very much, Dr. Ko. And Dr. Hee-sung Ko did log in and see you talk, so she just sent me the email. Okay.
All right, that's great. Thank you so much.
Thank you. So my name is Cecilia Yoon, and I will be moderating the next session on women's health. We have two leading physicians who will be speaking, followed by Q&A. So the first speaker is Dr. Linda Lee, who is the medical director of endoscopy at Harvard Medical School, and the topic of her lecture is women's GI health. I'm sorry. There was a little bit of a glitch on Zoom, so we will just give us a few minutes to start. Okay. So we'll go on to the next speaker. Actually, there's been a little issue. So we will go to Dr. Ja-hyun Shin. She is the director of minimally invasive gynecologic surgery, an assistant professor at Weill Cornell Medicine, and the title of her talk is Disease-Focused Programs and Minimally Invasive Gynecologic Surgery, a multidisciplinary approach to fibroid and endometriosis management. So apologies. So again, we're having a little technical issue. So we'll go on to actually the break time at this point and go back to hopefully the schedule. So apologies again.
Hi, Dr. Bailey.
Hi. I'm ready to go whenever you need me.
Well, hold on, I'm sorry.
Slide. Okay.
Hello, welcome back, and thank you all for joining. It is now my pleasure to introduce the CAMA 2021 President, Dr. Mary Choi, who will provide an introduction for our keynote speaker. Thank you.
Hello. So it is with great honor that I introduce our next keynote speaker, Dr. Susan Bailey, who is the immediate past president of the American Medical Association. And Dr. Bailey is a distinguished allergist and immunologist from Fort Worth, Texas, and was the 175th president of AMA. She completed her term as the AMA president in June of this year. Dr. Bailey has been active in the AMA actually since medical school, when she served as chair of the AMA Medical Student Section, and since has held numerous leadership positions with the AMA. She served as Speaker of the AMA House of Delegates for 4 years, and as Vice Speaker for 4 years. She also served as the chair of both the Advisory Panel on Women in Medicine and the AMA Council on Medical Education, as well as representing the AMA on the Accreditation Council for Continuing Medical Education and the American Board of Medical Specialties. Her long history of service in helping guide organized medicine extends to the local and state level as well, where she served as board chair and president of the Tarrant County Medical Society, and as vice speaker, speaker, and then president of the Texas Medical Association. Dr. Bailey is an allergist in private practice and has been with Fort Worth Allergy and Asthma Associates for over 30 years. She completed her residency in general pediatrics and a fellowship in allergy and immunology at Mayo Graduate School of Medicine in Rochester, Minnesota, and is board certified in allergy and immunology and pediatrics, and has been awarded the title of Distinguished Fellow of the American College of Allergy, Asthma, and Immunology. In addition to receiving her medical degree with honors from the Texas A&M University College of Medicine as a member of its charter class, Dr. Bailey was later appointed to the Texas A&M System Board of Regents by then Governor George W. Bush, and has been named a distinguished alumnus of Texas A&M University and of Texas A&M University College of Medicine. Dr. Bailey is married to W. Douglas Bailey, has 2 sons and 1 grandson, and is an elder and longtime choir member of her church. And this past summer, we had the honor of having Dr. Bailey joining CAMA's Women in Medicine Symposium, and we're very much looking forward to Dr. Bailey's keynote address on closing the gender divide in medicine. So Dr. Bailey.
Thank you so much for that very kind introduction. It's wonderful to be here with you virtually. I hope you are all having a wonderful time together in Seoul and enjoying seeing old friends and making new ones. As I said in my welcoming remarks yesterday, this year's themes of diversity, innovation, and cures captures the best of what organized medicine is working to achieve today and far into the future. We're working in partnership with one another to create a future for healthcare that's more accessible and equitable to patients, and that also promotes greater diversity in our physician ranks and across the healthcare workforce. Now, in some ways, the healthcare environment of today and its support of women physicians is light years ahead of where it was when I entered medicine, these many years ago. But in other ways, it really hasn't advanced very far at all. Now, while it's true that women are increasingly represented in medicine and now outnumber men in medical schools in the United States, it's also true that women are still far underrepresented in leadership roles in medicine, business, and academia. The AMA is committed to cultivating and empowering women leaders in medicine and establishing a clear pipeline to increase women's representation in the House of Medicine. We have longstanding policies addressing gender and pay disparities in medicine and in identifying and eliminating discrimination in the workplace when it occurs. Like CAMA, and I'm very impressed with CAMA in this regard, the AMA strongly supports women in leadership roles, providing the tools, resources, and opportunities for professional development and growth. Now, as the immediate past president of the AMA, and obviously a female physician, I believe that women bring special qualities to medicine, which is well researched and increasingly well documented. So the more women in healthcare, I believe, the better it is for patients, the clinical working environment, and our entire healthcare system. Now, during our time today, while I'm going to attempt to share my screen, there we go. We'll look at areas where we need to improve, where we must do better in areas of compensation, leadership opportunities for women, and support for working mothers. Organized medicine plays a critical role in helping bridge these gaps, both in the US and around the world. I'll explore some of the ways the AMA is trying to put women on more equal footing with men in the healthcare arena and where there are opportunities to do even more. So many of you are familiar with Dr. Elizabeth Blackwell, the first woman to earn a medical degree in the United States in 1849, actually just 2 years after the AMA was founded. And this quote, I think, was so wise and so prescient. Medicine is so broad a field, she said, so closely interwoven with general interests, dealing as it does with all ages, sexes, and classes, and yet of so personal a character in its individual appreciations that it must be regarded as one of those great departments of work in which the cooperation of men and women is needed to fulfill all its requirements. Now, Dr. Blackwell recognized that medicine is an endeavor that we all have roles to play in, and she worked for her entire professional life to open up opportunities for women to be educated, to train, and to work in the field of medicine. So in 170 years, we've gone from women being excluded from the medical profession to a point where women are now being admitted to medical school at a higher rate than men. And in fact, the past few years have been an historic time for women in medicine. From 2018 to 2021, I was so privileged to be among 3 women leading the AMA as president consecutively, the first in our 174-year history. Now, leadership in this moment is critical, and women have more than stepped up to the challenge. I am so proud to be among this impressive group of leaders. My colleagues, whom you see here, Dr. Barbara McEnany and Dr. Patrice Harris, are respected influencers, thought leaders, and trusted voices in the field of organized medicine, and I'm humbled to be among them. You never know what healthcare challenges you'll face when it's your turn in the leadership spotlight. Now, my term as president, as I'm sure it was for many of you, just happened to coincide with a global pandemic. It's been an honor to serve in this historic period for medicine, but also incredibly difficult. We have had to pivot in ways that we never have before in order to stay in touch with the physicians of America and especially our members, and to make a real contribution to helping learn about the pandemic and defeat the pandemic. Now, as we saw in the previous slide, the AMA recently had 3 women in a row as president, and it's just one indicator how more women than ever are climbing the ranks of leadership within organized medicine. But while we've achieved these impressive gains, deep disparities still exist. We'll talk a little bit more about this, but let's start with a little bit of good news. Women as a group have made great strides in medicine in recent decades. We make up over a third, about 36% of the physician workforce in the US, compared with just 5% the year I started in high school in 1970. Half of all US medical students and graduates are women. Nearly 40% of faculty posts at the nation's medical schools are held by women. But there are disparities that are still pervasive for women and people of color across healthcare. Just to cite a few statistics, on average, female physicians earn about 36% less than their male colleagues, and this is consistent across medical specialties. Salaries for female physicians at medical schools are generally lower than for male physicians. Women make up about 40% of full-time medical school faculty, as I mentioned on the last slide, but only 25% of tenured faculty. Only 18% of medical school department chairs and deans are women. And about 12 to 13% are the deans of medical schools. And not surprisingly, women physicians are at increased risk of burnout because of the work-life balance and shouldering responsibilities at home. And women are underrepresented in corporate leadership as a whole in the United States. Now, this is a McKinsey & Company survey. They do this every year, looking at women in the workplace. And they show some improvements, but not nearly enough. Only about 1 in 5 C-suite corporate leaders in healthcare is female, and fewer than 1 in 30 is a woman of color. Now, this slide goes from 2016 to 2021 and shows that there have been improvements in the various ranks of entry-level managers, senior managers, vice president, senior vice president, and then corporate leaders. But the gains, when you look at them, are really pretty small. This year's Women in the Workplace study also showed the immense toll of the pandemic on working women as they juggle responsibilities at work and at home. You know, I was naive enough to think at the beginning of the pandemic, when so many people were working from home that had never done it before, that there would be a greater appreciation of the important role that women play, and perhaps somewhat leveling of the playing field, if you will, in terms of responsibilities of work at home. But silly me, that has not happened. This year's study showed that women in the United States are even more burned out now than they were just a year ago. The gap in burnout between women and men has almost doubled. Women who are senior leaders or managers are more likely to be burned out, chronically stressed, or exhausted than men. And here you can see in the overall population and in the senior leadership, significant gaps between men and women. 1 in 3 women has considered downshifting or leaving the workforce altogether in the past year, an increase from 1 in 4 in the first few months of the pandemic. Working mothers, as I'm sure none of you are surprised, have been hit particularly hard by the pandemic. Working mothers full-time spend 50% more time each day caring for their children than fathers working full-time. Now, recent studies also found that mothers took on a greater share of tasks, including their own work, as well as facilitating learning for children and owning household responsibilities. In cases where the women worked remotely and the male partner did not, this was especially true. Women physicians, like I said, across every specialty lag behind men. Now, this is a compensation excuse me, study from Medscape. And this was this year's study. Medscape does these surveys every year and then breaks out some of the different demographic areas. In this survey, men earn significantly more than women. And if we take a look at a particular specialty, primary care, for instance, we see more of that disparity even today. Now, in this year's report, among primary care physicians, male primary care physicians earned $269,000 per year on the average, compared to 211,000 for female primary care physicians. And this is a 27% gap. And the gap is even more pronounced in specialists. Pretty close to our percentages in medicine as a whole. About a third of specialists are women, but they still earn less than their male colleagues. And this more closely resembles the overall wage gap for physicians of 35% more than women. Now, women have unique challenges and concerns in the workplace as well. Before the pandemic, AMA conducted a survey among women physicians to better understand their experiences. So I want you to remember I'm about to discuss some pre-pandemic data. We learned, not surprisingly, that physician mothers struggle to maintain a work-life balance. The Association of American Medical Colleges also conducted a survey with similar results. Family responsibilities impact female physicians more than their male colleagues. And according to the AAMC survey, 40% of women physicians go part-time or leave medicine altogether within 6 years of completing their residencies. Dr. Elena Frank of the University of Michigan Medical School said, until system-wide reforms are made within the institution of medicine to better support women in their roles as mothers and physicians, significant gender disparities in physician retention will persist. Now, these concerning trends, of course, have been exacerbated over the past 2 years, and COVID-19 has brought new levels of stress across healthcare, touching every aspect of what we do. The pressures of this pandemic on physicians and our healthcare workforce make it even more important that we develop systems to better support women as colleagues and leaders. Now, this somewhat busy slide goes back to the AMA survey that we did. It lets us know that we've got lots of work to do to ensure that our female physicians and working mothers are supported, are valued, and compensated accordingly. So you can see here, the brighter the color, the less applicable. And as we get into the grays, we strongly agree. And the survey revealed that about 40% struggled to maintain a healthy work-life balance. 31% felt a great sense of stress because of their jobs. 25% believed that the responsibilities of caring for aging parents, we hadn't talked about that yet, rested on women physicians more than on male physicians. 39% said that managing work and family was stressful, and on and on. We see these trends more and more. And, you know, I experienced these things myself. I was a single mom in private practice with 2 young children for a significant part of my career. And it was really, really hard. I had to have a plan A and a plan B and a plan C and a plan D. And one of the reasons that I chose private practice over academia is because I felt that it would give me a greater flexibility over my own schedule. I missed some opportunities that I think I would have really enjoyed and benefited from in academic medicine, but I'm not sure I could have made it work any other way. Now, according to the AMA survey, 79% of respondents strongly agreed that childcare responsibilities tend to fall on working female physicians. Only 1% of the respondents disagreed with that. Now, when we look at basic household activities, this is really getting, you know, down and dirty. 79% with kids under 18, the women have to do the laundry. 62% are responsible for the household shopping. 57% are responsible for dinner. And the level of support of a workplace has a significant impact on the outlook and longevity for working mothers. Only 8% agreed that they had adequate childcare opportunities available at their work, and 54% strongly disagreed with that. 34% either disagreed or strongly disagreed that their workplace family or maternity leave policies was responsive to women physicians. 31% disagreed or strongly disagreed that their workplace provides adequate support of women physicians returning after childbirth. And only 9% said their workplace provided adequate support for managing work and family responsibilities. And it looks like I've been a slide behind. So let's take a look at what it would take to build a more equitable future for healthcare for women. Now, the AMA is committed to supporting women in a variety of ways, including through the Women Physicians section. The section provides a proven leadership pipeline and is working to grow the ranks of women that are in leadership opportunities in the organization. More women in our House of Delegates, more women on councils and committees, more women on the Board of Trustees. We have women-led communities to share ideas, advice, and common concerns. We provide scholarship support for women medical students, professional guidance and mentorship, and support for managing work-life balance. We also have a special fund, the Joan Giamalvo Fund for the Advancement of Women, that provides grants of up to $10,000 to support research advancing the study of women in the medical profession and strengthening the AMA's ability to identify and address the issues affecting women physicians and medical students. We have granted 31 of these research awards so far. Now, this year's recipients are advancing projects creating a framework to retain female faculty and examining the role of gender on learner assessments in medical education. I'll get this down. The AMA strongly supports women in leadership roles and tries to provide them with the tools, the resources, and the opportunities for professional development and growth. And we support and encourage other organizations putting systems into place to alleviate this added stress on working women, including instituting family-friendly policies, childcare services on site, career flexibility, regular salary reviews, bias training, creating formal mentoring programs, and better defined reporting systems for harassment. In 2019, a report issued at our AMA meeting put our words behind the work already underway to cultivate a new generation of women physicians as leaders and to increase their representation in our House of Delegates, our Congress of Medicine, if you will, which is where we make our policy. And a quote from this report: promoting gender equity in medicine requires an acknowledgement of the underlying causes of gender-based disparities, creation of policies and resources that will promote gender equity, and collaboration to improve the environment for women and the profession as a whole. So in closing, on behalf of the AMA, I want to thank you for allowing me the opportunity to be a part of this important conversation on advancing women leaders in medicine. To move toward that vision we want for medicine, we must create better systems to identify, support, train, and advance women leaders. Conversations like this one are very important steps toward achieving that vision. So thank you once again for including me in your meeting this year, and I'm happy to answer any questions you might have in my remaining time. Thanks.
Thank you so much, Dr. Bailey, and thank you for being able to attend tonight. I am monitoring the chat for questions, but I wanted to start with you, as you mentioned, the gap is closing, especially in healthcare between the disparities that happen across the genders. Do you have any suggestions or recommendations for us as women in medicine around negotiations on how we can help to continue to close that gap when we look at positions either of employment or leadership moving forward?
Well, I think the first thing that needs to be done whenever there's a problem is to recognize the problem and be able to express it in words. Unfortunately, pay policies in many institutions are very secret, and employers don't necessarily want, you know, Dr. A to know what Dr. B is making for fear that that might, you know, cause some strife. But I think that when, you know, women need to go into salary negotiations with the realization that more often than not, they are not being paid at a level equitable to their male colleagues, and not be afraid to express that, to ask that, to say, am I making the same as a male physician who's, you know, been out of training as many years as I have and has the same level experience as I have, works the number of hours that I work, contributes the things that I contribute to this department. I think we have to be very intentional about these things and not just hope that it will happen if we're nice and if we smile. And I think that we have to be our own advocates because really, when you get down to it, nobody else will be.
Thank you. And as women leaders now in CAMA, thank you so much for setting those standards for us with the AMA that we hope to be able to replicate here in our organization. What are some of the suggestions that you can have, that you can provide for us so that we can better support our CAMA members?
Well, I think it's important to make sure that you have identified a mechanism for entry-level grassroots women physicians to become involved, whether it's in, you know, committees or, you know, whatever type of grassroots, you know, work that you have, you know, make sure that there are opportunities. That's one of the, I think, the most important things about our AMA Women Physicians section that I mentioned. Every woman who is a member of the AMA is automatically a member of the section and is eligible to participate in their activities, to vote on policy issues, and come to the meeting, you know, if they so desire. I also think it's important for us to realize that it's okay to start at the bottom and work your way up to the top. That's certainly what I did. I was very methodical in my approach, starting, you know, at the smallest committee and then achieving president of the AMA. It was a long, but it was a very, you know, methodical path, and help women that want to get involved. Help women see that there are opportunities for them, and you know, you are leading by example with the CAMA board being mostly women. I think sends a very strong message as to how important you believe this is.
Well, thank you again. Your support over the past 2 years with CAMA has truly been invaluable. I'm very sad that you're not here to join us in person, but I do thank you for spending your evening with us tonight.
Thank you.
And then I'd like to introduce our next session, which is the Women in Medicine panel. And we will have Michelle Kim, our convention chair, moderate the session, and we'll introduce the panel members.
Thank you so much, Ara. It's really quite a pleasure to have this very talented group of women for this next session. I think that we're going to be having some people from the United States, both on Zoom and as well in person. And so I'd just like to very briefly introduce all of our distinguished female panelists today. First, we have, perhaps to my left here, we have Dr. Aram Kim,
who is the Assistant Professor of General Internal Medicine and Hospital Medicine at Weill Cornell Medicine. We also have Dr. If you'd like to introduce yourself.
My name is Dr. Jinon. I am a pulmonologist and intensivist at Asan Medical Center. Yeah.
Hi, my name is Eunjung Ri. I'm an endocrinologist and diabetologist in Gangbuk Samsung Hospital, Sungkyunkwan University, South Korea. I'm greatly honored to be here. Thank you.
Thank you. I should say for anyone who doesn't know who I am, I'm Michelle Kim, Professor of Medicine at Mount Sinai School of Medicine in New York. And I'm going to go now to our virtual panelist. Dr. Chun, if you could perhaps introduce yourself.
Sure. My name is Yoon Chun. I'm a plastic surgeon at the Brigham and Women's Hospital. I'm an associate professor in surgery, and it's a pleasure to be here. And thank you so much for inviting me.
Thank you. And Dr. Cho?
Hi, my name is Soo-Jung Cho. I'm an assistant professor in pulmonary and critical care medicine at Cornell Medical College. And as a matter of fact, I graduated Seoul National University in 2003 and came to the States afterwards. And I'd like to say thank you so much for these wonderful opportunities to participate in the Women in Medicine Forum. And I really appreciate KAMA emphasizing the role of women in medicine. Thank you.
Wonderful. Thank you so much. We're really so pleased to have this panel. I wish that it was all in person, but so grateful to have you here. So perhaps I could just open with one question, sort of broad question, and I'd like to open it to any of the panelists who would like to who'd like to start us off. And it's really just a question: how did being a woman affect or influence your career? Whether it was your choice of your specialty, whether it was your training, or whether it has something to do with your advancement as a faculty position. Would anyone like to give it a shot?
Yeah, I'm now in the intensivist and in charge of the medical intensive care unit at Asan Medical Center. Since 2005, I have worked as an academic faculty member. So women physician and even intensivist is so few at that time. So I'm still struggling to survive in the sector. So, but my goal is simple and one. I wanted to be a good physician to manage the critical ill patient. So it required on-call a lot and working long time. So it was very hard work to stand on my position, but it has been rewarding and worthwhile. So my colleague often say you are now a senior professor, but I still think I'm working like a junior. So I am struggling now.
I think we can all understand that. Dr. Rhee, would you like to comment perhaps?
Yes, I think it depends on what field you're in, because personally, I don't think I had any disadvantages or disparities during my career, because I'm an endocrinologist and diabetologist, and I see patients with diabetes, and when we see these patients, we have to have this very comprehensive eyes on our patients. We're not looking at their glycemic values or HbA1c, but we also have to look for any complications that they have. So I think I always used to think that female endocrinologists would have much better, they would be superior to men endocrinologists, because they could see their patients comprehensively better than men doctors, because we have this ability to see our patients just like a mother looking at their child. So, and during my career, I didn't feel any disparities, because my mentor used to tell me that women doctors are much more excellent than men doctors. And that's how my father brought me up also. So I never felt, and I tried not to think that I would have any disadvantages during my career, because that would make some of my men peers as an enemy to me. So I tried not to think that way.
That's very interesting. So we've just heard a terrific talk from Dr. Bailey about some of the ways where women lag behind our male colleagues, but you actually describe it as an advantage. So that's a really interesting point. Dr. Kim?
Yeah, reflecting on this question, I don't think that I was acutely aware of my gender in my choice in specialty or choice in career path, but I'm starting to realize that a lot of my choices were sort of subconsciously based on who I was looking at in the field that I was hoping to be joining. When I was looking at medical schools, the medical school that I ended up joining had sent me a pamphlet that had an assistant dean of research who was a Korean American woman, actually. And that really inspired me to look into that school and be a little bit more interested. And same with internal medicine. I think that I really looked up to several women physicians who were residents when I was a student, who embodied the kind of physician that I really wanted to become, a warm-hearted, empathetic, and really strong clinically type of physician. And I think subconsciously those influences have shaped my decisions to kind of get me to where I am right now.
Thank you so much. So really the importance of representation, perhaps in gender and also in background in our country of origin. I'd love to hear a little bit more from our virtual panelists, Dr. Cho and Dr. Chun, especially Dr. Chun as a surgeon. I wonder if you can perhaps have some more specific comments, I guess being a woman and choosing your specialty, and particularly I think in a female-oriented field that you have breast reconstruction as your specialty.
Yeah, sure. So I think part of it is luck. When I went to medical school, I actually had no intention of doing surgery. And I think part of the barrier was the amount of training and the hours and the challenging process. So I went to medical school to be a pediatrician. So that was my goal. But for whatever reason, during my surgical rotation, I had a chief resident who was a Indian American minority female, and she was probably one of the best doctors that I've ever encountered in medical school. Despite the grueling hours, she was the most patient, and she taught, and she was probably one of the most technically gifted surgeons that I've ever seen, even compared to the attendings. So I think seeing someone like that as a role model really does influence how you think about your career path, and it really opened a whole nother world in terms of my career path when I was looking into surgery. I think now my subspecialty is in breast reconstruction, and that particular subspecialty is affected by my gender. I was the first female partner in our division, and although I never really intended my subspecialty to be in breast reconstruction, because I was female, a lot of the breast cancer patients started to be referred to me, and I think there's some special connection that breast cancer patients might have when discussing these reconstructive needs with a female surgeon versus a male surgeon. So I do really treasure that, and I think it's one of the most gratifying things that I see every day in my career. So I think that has really helped a lot in terms of me being a female surgeon here.
Thank you so much, Dr. Chun. Dr. Cho, I think you're a scientist doing translational research. I don't know if you'd like to comment in any way on that, or in any other way that being a woman has affected your career.
Yeah, sure. First of all, I want to echo on Jin-Won 교수님 that I feel the same way. I'm also in the same specialty in pulmonary and critical care medicine, and being a woman in that field, you got to be tough. But but I just want to have a little bit of a storytelling about my past, how I came to the States, because during that journey, I took advantage of being a woman, which is considered to be a disadvantage. So as you know, there is 2 or 3 years of mandatory military training for all Korean men, including men physicians. And I was told, when I was in medical school, I was told at that time Typically, women physicians had to wait for a couple of years for the appointment as a faculty members, while male doctors are in military training. So as a medical student, I thought, I don't want to just waste my time waiting for my classmates to come back to the hospital. So I'd rather use this time to gain more life experience. So some of my female friends also took a gap year for a personal interest, such as travel, and I decided to go abroad. So as a 24-year-old senior student, I sent my applications to labs in the United States. And I was fortunate to join a lab at Yale as a postdoc, and my preclinical training in research began. So I felt that the decision to come to the US was relatively easy for me because I was a woman. So as Dr. Bailey said, you have to take some methodological approach. And I think being a woman in Korean gave me an opportunity to come to the States.
Thank you so much for sharing that personal experience. I'm so inspired just sitting next to all of you and hearing what a joy it is to meet all of you. So we've talked a little bit about perhaps some of the ways that being a woman has influenced your career. Now I wonder if we can move a little bit to perhaps some of the challenges and barriers that you have faced, whether it has been something very specific like a sexism, type of event, or whether it's something more subtle than that, perhaps something where someone just made assumptions, had unconscious bias that you would not do something because you were a woman, or any other challenge or barrier. Perhaps we'll start with our colleagues virtually. Dr. Chun, would you like to comment?
Well, I think I was lucky during training that I didn't really face too many challenges in terms of being treated differently from the male counterparts. But the most significant difference that I noticed was after having children. So as I started my practice as an attending, that's when actually my first child was born, 2 days after I graduated from residency. So it was a little bit, stressful times to begin with. And I felt that some of my personal decisions that I made for raising my family and other commitments outside of the work, it wasn't really consistent with the measure of value at work. So I think that was probably the most hardest thing as a female. As a surgeon, I think there's this traditional definition of value where they consider doing complex cases or long microsurgical cases, especially in plastic surgery, is given more respect and value. The longer you stay in the hospital, the longer you see patients at night, the more emails you send out at midnight or 2 in the morning. Those are kind of considered as valuable things, and it really wasn't going to be compatible with a newborn or raising kids or taking care of elderly parents. So I think that was difficult in terms of trying to balance that. Meanwhile, I noticed that my male colleagues would openly, say, "Oh, I'm going to take off after the morning so that I can attend my daughter's dance recital or attend sporting events." And for some reason, when they made those statements, they were viewed as, "Oh my God, you're such a family person. You're a doctor, you're a surgeon, but then you spend all your time with your daughters and attend these important events." But I think for a female surgeon or female doctor, I don't think we have the luxury of being able to share those opinions or being able to make those same decisions. So I think that's probably one of the most challenging things that I encountered once the kids came and other commitments started to grow.
Thank you so much. I don't know if you can see us, Dr. Chun, but there's a lot of nodding going on in this panel, and I think also in our audience. I think that what you say really rings true for a lot of us. Perhaps going to some of our panelists here in person.
Okay, I had very similar experience also, because the difficulty actually came when my daughter was born. And I think Korean society is the mostly difficult society that women doctor as a faculty member and as a university professor could actually raise their own child, because this society and our university and our hospital expect too much things for us, because we don't only see patients, and we have to be very good wife and nice daughter, and at the same time, nice daughter-in-laws in Korean culture, and at the same time, very good wife and mother. But also, we have to be a good professor for our students, and also we have to be very good researchers, because for our career, we have to write papers and also do the research. So yeah, because I had experience of living in the US for 1 year in 2010, and at that time I had to raise my daughter, and I had also experience in Korea. But I think both societies, but actually in the US there were some kind of more favorable for like when you do something for your child, they kind of admit it in your work. But in Korea, but it would be different in medical field. But in Korea, when we say that, like our boss or our PIs will think that, okay, you're a woman and you're not working harder than your male colleagues. So it was really difficult for us to have more child. That's why I had only one daughter, because I had no guts to tell my boss that I'm going to have one more child. So, you know, it was the most difficult time that during raising my child in Korean society as a medical doctor, and also at the same time professor, and at the same time, yes, as a family member. It was really difficult for me. Yes.
So it is just my personal experience. It took a long time to get to where I am now. So I had to bridge the so-called class ceiling because since the women intensivity is so few at that time, so it is difficult for me to understand, to adjust to company gathering here in Korea, because I am not a big drinker, so yeah, it is very difficult. And the women physician or professor was in the minority at that time, so I was terrified that my personal mistake would be identified as the mistake the women physician. So I tried and tried. So I have no choice to work hard. So now that I think about it, I believe the prejudice is for granted. So my solution has been to work as though there is no gender distinction. So fortunately, I met a great mentor, but he is man physician, so he guided me through my academic career and had given me the opportunity to promote myself. So my good luck is to meet a good mentor in my academic career. I think so. Yeah.
Thank you so much. Dr. Kim, would you like to comment?
Yeah, I'm really inspired by the personal experiences shared by my co-panelists today as I'm reflecting on the past year. I keep saying I just had a baby. It's been a year, but I have a 1-year-old daughter at home. So it's been definitely a huge change in my work life and life in general. I can say that I've been very fortunate in being very well supported at work for my decision to have a family, and I have fortunately not faced any discrimination or disadvantages for having made that choice. But in a sort of different perspective, speaking on the challenges of a woman physician at work, I think many of my co-panelists, as well as those in the audience, may relate. As a woman physician, and particularly as a young female Asian physician at the workplace in the US, I often, almost all the time, am mistaken for the intern or the resident when I walk into rounds. at the bedside with my team, and often the tall or the white or the male, always the male resident, is mistaken for the attending physician. I also find that, as a female physician, I'm often asked by the patient to carry out tasks that they often don't ask our male counterparts. Even the male residents don't get asked to refill the jug of water or bring over the urinal, or things that patients typically don't think of asking a doctor. I get often asked, I just wanted to kind of bring that different aspect to the discussion.
Do you mind commenting on the impact of that? I mean, how does that make you feel, and how does that make you, I guess, sort of conduct your career or conduct yourself differently?
Yeah, I think so. I've been an attending for 4 years now, and initially I was much, it was much easier for me to just oblige to carry out those tasks because it's faster that way, and I'll get out of the room faster if I don't argue with that. But I've noticed that that's had been wearing on my conscience and my morale at work and my identity as a woman physician. And I also worried about the impact it would leave on my female trainees that I am with. So I've been, as I'm becoming, a little bit more senior year by year, I'm a lot more aware of the influence that my actions and my lack of actions can have on my trainees and my female and my male trainees equally. So I've been training myself to be a little bit more vocal, to be a little bit more fair to myself in dealing with those situations without creating a scene or making it confrontational, but making it very professional and finding different solutions, different ways to nicely get out of that situation, if that makes sense.
Right, thank you so much. Now, it requires some adjustment there to correct a patient or to address that in a different way than perhaps you might normally do. Dr. Joe, I think we didn't have you comment on this question again, some challenges or barriers that you faced.
So of course. So I concur with everyone's experiences. I had a little bit of everything. I have 2 children as well. But I want to touch upon a little bit different aspect of being a woman. So I've had both positive and negative experiences as a woman in medicine. It goes back as early as when I was a medical student. Our class was comprised of like 40-something female students, which was about a quarter of the total students. Although female students were minority, they usually had higher grades on average and had better performances in general. However, later in the senior year, I learned that the female students were not only evaluated by grades, but also judged by their appearances. For an extreme example, once I was asked by one of the professors to pull down my mask during the rounds. And later I found out that he wanted to see my face. And he asked me some embarrassing questions as well. So I was humiliated at that time. And looking back, it was almost like a sexual harassment by definition. So based on these experiences, I realized that being a woman in medicine was not easy. And these experiences also made me learn how to be a stronger woman in medicine. And then later on, I learned how to speak up for the gender discrimination, disparity, along with my courageous friends. So this is my personal experience that I want to share.
Thank you so much. I think that all of our panelists have really commented so personally and very articulately on how all of the experiences that you've had during your training and your career can really impact you. And it sounds like also a lot of our physicians here have a sense of responsibility for anybody who may be watching, particularly trainees. And so that, of course, is a real responsibility as well. So I wonder, some of you had mentioned some of the potential opportunities, that it's not always a a barrier, it's not always a challenge, but that sometimes being a Korean American woman can work to your favor. I can say, from my point of view, that something I've noticed now being a little bit more senior is that there is a bigger push to diversity, and so being a senior gastroenterologist where there are not that many women, that actually there are many more opportunities now because they are looking for more diversity and they would like to have different voices. What are you finding are some of the opportunities actually being a woman in medicine? Are you finding that there are more now than there used to be, or is this just something that I happen to be experiencing?
Sorry, no, I have never had any special opportunity as a woman, especially in my specialist is not kind to women. So in our department, there are 5 academic staff. So about them, the women is just one, it's me. So the environment is rapidly changing, is more diversity and generous to women, but men, but there is no special opportunity as a woman in Korea, just as I know, yeah.
Any of our other panelists? Is this just an isolated experience then that I'm noticing perhaps in gastroenterology, or are you noticing any other opportunities that you're having?
I think that, oh, sorry, was someone going?
Go ahead.
Oh, a few years back, Dr. Mary Choi hosted a Women in Medicine chapter at Weill Cornell, where a lot of women scientists, women physicians got together and were able to connect and share some of our common experiences. And that's one of the places where I met Dr. Cho. And through that gathering and continued opportunities to network with other women physicians at Weill Cornell, it created a great opportunity to find mentorship, to find camaraderie, and I thought that was a very unique experience that, typically doesn't happen. There is no Men in Medicine chapter at Cornell, and so, I did appreciate that opportunity that was given to me as a Korean American physician, particularly as a woman physician, to be able to find mentorship in physicians who were, like me in background and interest. So that was really special.
Thank you. Dr. Chun, I think you were about to say something, is that right?
Oh, I was just going to comment that I have noticed there have been a lot more increasing invitations to participate in committees and especially diversity, equity, inclusion type of committees these days. So I do welcome those opportunities, and I think being an Asian American or Korean American female is helpful. This might be myself being a little bit more cynical in that. But I have also noticed it doesn't necessarily come with time, additional time. So you're still expected to do all the clinical responsibilities, the clinical research, which I love doing. But then I noticed that there are now increasing amounts of administrative responsibilities that comes with these committee work. So I do have sometimes some mixed feelings about this. Because I wonder sometimes whether am I really providing meaningful work that's going to translate into something greater, or is this more of a checking off the box within the institution to support this concept, but without a real translating that into a real entity at the end. Perhaps it will take time. I think this is only the beginning, and I'm glad to be a part of that initial process. But I'm hopeful that it will translate to something more meaningful down the road.
Thank you so much. I think in the States we call that the minority tax, right? Is that you are being asked to perhaps do more interviews for residency or medical school or fellowship applications, that you're being asked to be the female voice on a committee, and so, as you said, unless that translates to increased resources, whether it's with regards to time or salary, that can be just then a time a dedication of time and not necessarily anything else. I don't know if you wanted to comment also, or no, not really. Okay. So
Can I make a comment?
Oh, of course, yes.
Real quickly. So I agree with Dr. Kim and Dr. Chun that being an Asian woman physician is not a disadvantage, but a very unique and special. And yesterday, I want to point out that Dr. Lisa Park, an ophthalmologist at Columbia, gave a beautiful lecture. And at the end of the lecture, she shared her interaction with her daughter, who was inspired by her mother. And I almost broke into tears. As a woman in medicine, we can inspire our own children, but not only that, we could inspire each other, other women physicians and scientists in medicine as well. As a matter of fact, I have two awesome mentors, Dr. Augustine Choi and Dr. Scott Delgado. And Dr. Choi, who is a male physician, but he has a tremendous respect towards women physicians. And he has been supportive me throughout my pregnancy and child caring stage. And Dr. Scott Delgado, who is a mother herself of two beautiful daughters, and she serves as a role model for women in science. So both of my mentors were truly inspirational, and I hope I could be a role model and a mentor like them, and who can inspire younger generations.
Thank you so much. Yes, go ahead.
Sorry. I think, yes, I was really surprised that I actually was surprised by the Professor Bailey's report about this disparities and discriminations between regarding this gender. And I thought today that I learned a lot that we have to look around us, for our women doctors and our women juniors, for if they have any problems or any difficulties. And then we have to try ourselves to become a very good women mentors for our residents and our trainees, so that many medical students or women doctors consider us as a role model, and they have the strength to further go for their future and do more strongly, probably better than their male colleagues. So I think we have to be better, we ourselves, to be a better mentor and better women doctors to make our female trainees better ones. Yes.
Thank you so much. I agree with you, that I think we are sort of naturally, even without being deliberate about it, that we are often mentors and role models for trainees, and particularly if they're Asian American and if they're women, that they will naturally see us and having a connection. My only other thought to add to that is perhaps that, again, it can be more of a responsibility than for the female physicians who are already being asked to do more. And so then I do think that it's why we so often include our male colleagues as well in that conversation, because it is something that is a larger responsibility, not just for the women alone. So many of you have mentioned mentors and sponsors. And so just for those who perhaps are not as clear on the distinction, the mentors are sort of more coaches and advisors, and then the sponsors are the people who, perhaps in your organization or in associations or societies are, actually asking you and putting you in different positions where you'll have opportunities. Can you speak a little bit to some of the mentors and sponsors who have been important to you, perhaps if they've been men or women or Korean or not, and just perhaps tell us a little bit about, some of the people who have been important in your careers.
Oh, yes. So I started endocrinology thanks to my mentor, Professor Sun-woo Kim. He used to be a professor in our hospital, but he's now in the medical director of a pharmaceutical company in Korea. And he's over 70 years now, but he's still doing his career. And actually, he's my role model, actually. And he always used to tell me from the time that I was a resident, that women doctors are much more excellent. You're going to be the top on your field. That's what he gave me. So, and I also have another mentor, Professor Won-young Lee, and he led me through this research work and everything. And I think this doing research and writing paper was the only weapon for me to not to be discriminated from my male colleagues. So I always tell my trainees, my female trainees, so what I say is, when you become something, they don't see you, but they only see your papers. So they don't care about whether you are, but it's different. It's just this endocrinology field. So I just tell them, just try to, to make more, write down more papers and make your careers. So anyway, I had very good mentors, and I hope that I want to be a great mentor, just like my mentors, to my trainees.
Thank you so much.
So I think the mentorship or sponsorship in Korea is very weak. So because I think most doctors focus on their clinical work than research work. So after finishing training and they move to new hospital, new job, and the interaction is interrupted. So only in small group that who are continue their academic career or the promotion themselves, only a small group continues the mentorship and sponsorship. So because it's Korean system is different from USA, so many doctors is not familiar to mentorship because they just they're working and finish it and move. So it's the most of their life. So because the Korean doctor is focused on the primary physician, the academic career is very weak. So yeah, I want to improve their academic career, even in very smart women physician, they interrupt their career because of their childbearing or the raising. So it is the sad story, yeah.
Thank you so much. Any further panelists? Any comments on your mentors, your sponsors, people who have been important in the development of your career?
I wanted to give a shout out to my boss, my mentor and sponsor, Dr. Evans, and not just doing that because he's sitting across from me right now, but it's truly been so wonderful working under Dr. Evans, who's the section chief of hospital medicine at Weill Cornell, because of his deep understanding of issues for women in medicine who are trying to make it in academia, and his passion for, sponsoring and mentoring and supporting our passions in medicine. I know I'm speaking on behalf of all of the women in my section that we all really admire and appreciate the mentorship that Dr. Evans provides. He's coached me through many different negotiations in obtaining different positions in my very short career at Cornell, and also encouraged me when I wasn't feeling very certain about myself, has really encouraged me to take on leadership positions and believe in myself.
Thank you so much for sharing, and it's really wonderful to hear again, the enlarged community that we can turn to when it comes to some of these more delicate issues when it comes to our career development. Perhaps our virtual panelists, would you like to comment a little bit about your mentors, your sponsors who have been important in your career development?
I briefly mentioned about Dr. Augustine Choi, the Dean of Weill Cornell Medicine, and he's been supportive for entire my career as a physician scientist. I still remember I was interviewing at Cornell by the time when I was planning on transferring from NYU, and I was 8 months pregnant. I was not in a good shape for an interviewee, and but he, welcomed with a big smile. He understood my challenges and difficulties. At the same time, he trusted me throughout my career. And at that time, I was facing multiple responsibilities, including research, clinical work, and raising 2 children under age 2. And he was generous enough to, wait for me. And I was able to, gather all my thoughts together and define, realize my limitations and potentials. And at the end of the day, I was able to focus on certain things that are priority, and then pursue the least important things later. So he was a true mentor, in my opinion, and also Dr. Scott Delgado, as a women scientist, she had the busiest life but at the same time, she was able to balance between work and home, and raising two beautiful daughters. She was writing, grants on the 1.5-hour train, and we were talking constantly every day about science and life. And she was like a friend and mentor to me. So I was truly blessed by both of my mentors.
Thank you so much for sharing that. Sounds like you had really a perfect situation there. I think you also highlighted, certainly the length of a career, that it's not, just a matter of a few years and you sort of have to get through it, but it can be, decades and decades of a long process. Dr. Chun, would you like to comment perhaps on your mentors and your sponsors?
Sure. I was very lucky to have two mentors, and one was our program director during my residency at the Harvard Plastic Surgery Program, and then my chief of plastic surgery at the time at the Brigham, Dr. Elof Erickson, who gave me my first position as faculty. So I'm very grateful. They were both supportive. I don't think there was any gender issue at all. They were just great surgeons, clinicians, researchers, and innovators that really provided a great mentorship and support throughout various stages of my life. Graduating from residency, having kids, and promotions and so on. I do think for younger women, it would be helpful to seek out your own mentors instead of just waiting passively for the leaders and other faculty to reach out to you. So I think there is some benefit in being more proactive and finding the one that might be the best fit in terms of your values and priorities.
Thank you so much. I imagine that we have a number of trainees who are sort of watching this conversation unfold. And something that we've been discussing at Mount Sinai, we actually just had a forum the other day. I don't know if you had seen that there was a New York Times article maybe a month or two ago where it featured that many women in medicine have issues with fertility and in terms of trying to have kids, and actually that the problem is much more widespread than one might think. We actually had a seminar at Mount Sinai discussing sort of reproductive options, and there was quite a bit of interest in that, in a very deeply personal topic. Many of you have talked about having kids. Could you speak a little bit to, I guess, what determined your timing of when this would happen, if it impacted your training, if you had difficulties seeking enough time off for certain, any health issues or anything like that? If you're comfortable sharing, please do.
Yes, I'll start. So I have one daughter. She's 21 years old right now, and I had her when I was in third year of residency. And at that time, I wanted to become a cardiologist at that time. But after I gave birth to my daughter, I was afraid of always have to wear because when you have to go into the coronary angiogram, you have to wear this gown to protect the radiation, and I was really not so had courage enough to that because at that time I was doing the breastfeeding at that time, so I actually gave up being a cardiologist, and also I was afraid that I had to have call all my life, just like professor in the critical medicine and everything. So I was really not so. I did not have the courage to all that. So but that's just partially the reason that I actually chose the endocrinology. And also, as I've told you before, that I wanted to have the second child, but actually I didn't have the courage to tell my boss that I'll have, and maybe I'll have some months off from my work. So I didn't have courage. But one of my woman colleague, actually, she had 2 children after she became a professor. And during almost totally 2 years, she was off the work. And many men colleagues did not like it so much. And I could hear that all. And I felt very painful for her. So yeah, that's my experience. But I don't know how to, because we had to, when we have to become a mother, so I don't know how to just, yeah. I don't think there is any solution for that.
I'm going to also reframe a little bit, I think, of what you said. I think it's not necessarily a lack of courage, but certainly much more the systemic issues that are preventing you from being able to make the choices that you would like to make, and at the same time also be able to have your personal choice. And so these are, of course, much larger issues than we're going to be able to solve today, but is something certainly that people can speak out about. Would anybody else like to comment on, again, choices of timing and how that might have impacted your choice of specialty or development?
I don't think there was any particular stress around, deciding that timing on when to have my child, but there was definitely a lot of support needed from, my section as well as my colleagues who had to fill in some of the work. As a hospitalist, in a way, my work is replaceable on the wards because we work weeks at a time, and when I'm off in maternity leave, somebody else can fill in that spot very easily. But as part of my academic work, I help direct the clerkship for medicine, so I'm the associate clerkship director, and the work there was not so easily replaceable, so I did rely on the extra work and support of my male colleagues who were filling in my work while I was gone. I tried to do my best in doing some of their work before I went on maternity leave to make it a little bit more easier on them and to make it fair. But I did end up, appreciating and relying a lot on their goodwill. One of them was a father himself, and the other, was not, but both of them were very willing to help out and were very understanding of the situation. And I think that normalizing paternity leave and making sure that our male colleagues also get protected family time when they invite a new family member is really crucial in making it equitable for all members of the team. And I know that nationwide and globally there's a push to increase paternity leave time to make it, less harsh on the woman when they have to ask for maternity leave, so that they're not getting pushback from their male colleagues or flack for taking time off when we have to for childbearing purposes. So I think that's very important.
That's great. So again, these systemic issues that, rather than having to ask for it, that is more just given to you and it's an expectation. And again, I think you're seeing here that there's a very intense awareness that when you are gone for whatever you're gone for, that there are people who have to cover, and that, that intense awareness, can sometimes sort of make us feel that sense of responsibility where, again, perhaps that is not something that we should be feeling when we're doing what is, I would say, an equally, if not more, difficult job. Perhaps I'll go over to our virtual panelists. Any comments on, again, timing of children or choices in that area?
I don't think there is, go ahead.
Dr. Chen, go ahead.
I don't think there is a perfect time to have kids or be pregnant. I think a lot of my colleagues and surgical friends have who are female have put off having babies because of the grueling hours and whatnot. And I do come across a lot of my colleagues who have regrets about that. And I think if having a family is an important value, then I don't think it should be compromised based on your career or your training. I had my first daughter right after graduating from residency, so I was pregnant with her during my chief residency, and I thought that was hard. But then having my second one after I had established my practice, it was not any easier. So I really don't think there is a perfect time, or I don't think it's realistic to plan these things out too much. And I think you just have to kind of see where the priorities are and just make sure that you're not missing out on the opportunity. And as Dr. Kim said earlier, it is a systemic problem. And I think it is getting better and that there's a lot more increasing support within the institutions, in the residency programs that are making it more favorable. But I still think we have more ways to go.
Thank you so much. Dr. Cho, did you want to say a few words?
Yeah, sure. I totally agree with Dr. Chan. There's no good timing. So for my personal experience, I got married right before my internship, but I decided to wait for 5 to 6 years until I finished my clinical training. In part, I didn't want to burden my colleagues, but also I want to spend more time with my child. So even when I had my first child in my senior year of my fellowship, I was only able to take off only 1 month using my own vacation time. And this may have been changed, but when I was a fellow, if you are going to take a maternity leave, you had to stay on your clinical training until you fulfill the length of training. So I didn't want to stay longer than it was necessary. So I chose to just use my 1 month of vacation for my maternity leave. So when I was pregnant with the second child, I was a second year attending. So I was able to take a couple of months off planned. So it was okay in that regards, but that was right around the time when I was transferring to another institution. So that was challenging. And as I mentioned before, I was 8 months pregnant when I was interviewing at Cornell. So, and I was facing more responsibilities than I was younger then, more clinical work, more research responsibilities, and raising 2 young children. So recognizing my limitations, and I decided to focus on research and childcare and hold off on the clinical work until my children was like 2 years old. So I kind of prioritized in that regard. That kind of held my promotion a couple of years back. But long story short, I don't regret my decision. And being a woman physician scientist, a working mom, a loving wife, we have to mention that too at some point, was only possible because I admitted my limitations and set my short-term and long-term goals and prioritized given tasks. So I learned throughout my career how to do this better and better, and that led me to where I am right now.
Thank you so much. It sounds like we had rather similar experiences, because I remember having my second child during my second year of fellowship, and I think the recommendation was to take 4 weeks of vacation all at once. Otherwise, I would have to come back later to stay longer beyond June 30th, and that was not quite an option. So I am sometimes relieved to hear that the situation has changed, but then also saddened to hear that the situation has not changed very much. It goes both ways. So I'd like to ask our panelists now to perhaps give some thought to, I guess, take-home messages for people who might be listening, men and women, and perhaps some best words of recommendation that you would want to leave people with somehow that take-home message.
Okay, I actually prepared the 4 messages, just 4 points. The first one, not for just women doctors, but for looking back, I think just being enthusiastic about tomorrow is a very good way to overcome the difficulties. So if you had any difficult day and then when you go to sleep, think about new days. There will be bad things, but there will be good things. It's to be enthusiastic about tomorrow. And second thing is that try to think that we don't have any disadvantages compared to our male colleague that would be positively change your future. And the third one is do not avoid or be afraid of new opportunities, because I think the greatest chance or opportunities always came unexpectedly. So sometimes, why do I have to go there and give this talk, or why do I have to do this, or why do I have to meet that one? But actually, that was the greatest chance. So I would say do not be afraid of new opportunities or unexpected chances. And lastly, for women junior doctors, just give up becoming a superwoman. We're not superwomen because, you know, all of us want to be a perfectionist, and they want to be a good mother and good professor and good doctor, but that's not actually possible. We're trying, but just do not just give up being superwoman. But you could be superwoman, but just don't consider you as a superwoman. That's the most comfortable way to be very have comfortable in your mind.
Yeah, certainly, we could be a little bit more forgiving, I think, of what we think are you know, such important things, but perhaps they're not as important as they seem to be.
Yes, so my talk is similar with her. So I always tell my junior women doctors the same story, which is that Superman is the world of fiction. So no one should be made to be Superman through force. So there are only 24 hours in a day for everyone. So now all you have to do is decide what is most important in your life and to work hard to get it. So please take some time to relax. So it's my talk, yeah.
Those are great words of advice. Thank you. Dr. Kim?
I think, you know, as you mentioned earlier, Dr. Kim, it's really important to have our male counterparts involved in this discussion. I think that's one of the points that I want to stress. Also to surround yourself with people who are really supportive of your values in life, of the things that you want to achieve in your career. And I know I'm still pretty junior, but you know, I try to instill these values in my interactions with my mentees and my trainees. And I hope that, you know, the mentees and trainees that I have touched will also go on and, you know, pay it forward to their mentees and trainees so that we can achieve a change in culture.
Thank you so much. Dr. Cho?
Sure. Remember Dr. Bailey's talk, and I agree with Dr. Bailey and other leaderships that we should continue to fight against gender disparity and promote gender equity in leadership roles, promotions, salary support, and scientific opportunities. However, we cannot do it as an individual. And I think this forum, Women in Medicine Forum, is part of it. We cannot do it as an individual, we can do it together. So in our division, we have a group chat comprises of 13 women, pulmonary critical care medicine faculty members, all women. And we talk about all sorts of stuff that are related to our work, childcare, funny jokes, and sometimes gender disparity issues. We cheer for each other's accomplishments and encourage each other's, especially during their difficulties. It is great to have a supportive group who is going through similar situations. So I would strongly recommend have a supportive system at your work, especially that are involving women in medicine.
Thank you so much. I think I agree with you that this is what this forum and all the other fora is about, is really making sure that we have a collective voice and not just one that speaks for one person. Thank you. Dr. Chun?
Well, I'm learning a lot from the whole panelists here today. I think the only thing that I might add is, you know, being kind to yourself, but also being kind to others. Although we're all, you know, women in medicine, there are, you know, variable circumstances, and not every situation is the same. There are single mothers raising kids and being a doctor. There are you know, women doctors with stay-at-home husbands, or you know, 2 full-time physician families. So I think sometimes women can be a little bit judgmental when it comes to different commitments and whatnot. And I think it would be helpful as a group to be kind to each other and be more empathetic, and also to have almost like a critical mass of women in leadership roles who can really prioritize these personal values that will help the junior faculty.
Thank you so much, Dr. Chun. I really would like to thank our distinguished panel today, those in person and also those from the States. Thank you so much for sharing your experience, your personal journey, and also your words of wisdom for those who might be listening. Thank you so very much. And with that, I think we'll conclude this session. I anticipate that the session will be just one of many others in the future. What started in 2017 as a Women in Medicine Forum that was sort of standing room only, and that went longer than its programmed time, that is now, I think, a recurring event. And so we hope that we can really build this community of women in medicine. Thank you so much. I think we're going to see you, everyone, after lunch, or in the States. It will be quite a bit later in the night. Thank you very much.
여기도 지금. 네, 잘 보여. 네, 문제 없을 것 같아요.
다 아시겠지만
네.
이거 두 개가
네. 하고 그 프리비어스인데.
네, 이거는 밑에 거는 레이저인데 굳이 레이저는 사용하실 필요가 없으실 거예요.
레이저 사용 복잡해.
네. 여기 노트북 안 올라가서 여기는 못 올리죠. 마이크 때문에. 왜요? 그냥 이렇게 넣으면 될 것 같은데. 두 번 10번. 9번 10번. 사회자가요? 아니 발표자가 두 명이고 사회자 두 명이고. 아니. 테라스인데 사회자가. 테라스는 사회자 두 개 있을 거 아니야. 테라스는 발표자 2명 얘기는 거 아닌가? 아니, 그거는 Q&A. 근데 저기서 하면 안 되는 거야? 굳이 여기서 해야 돼? 두 분이서 앉았다가 왔다 갔다 하면 되잖아요. 아니, 노트북이 저기 있고 여긴 볼 수가 없는데 그렇게 하려고 유도를 하든지 뭐 그렇게 해야지 뭐. 노트북을 넣을 수가 없어서 저기서 해달라 이렇게 얘기를 해야죠. 아니면 이 마이크를 여기로 위로 올리든지.
굳이 2개 설치할 필요 없지. 그냥 여기서 처음부터 그냥 저기 다 설치돼 있으니까 저기서 하는 걸로. 굳이.
저는 사회자분 여기서 동아라면서 해달라고 말씀드려야 될 것 같아요. 아니, 페나토는 어떻게 진행하는지 물어봐요. 확실히.
페나토론 진행하는 거는 사회자는 번갈아 가면서 하시고 두 분이서 의자 주시고 번갈아 가면서 하시고 나머지 그 패널 분들 네 분만 이런 식으로 해달라 했는데 저거를 그럼 반대 방향 딴거 말씀.
아, 저거요? 놀이터를?
모니터는 딱
네.
다 저는 의자만
I think we'll get started with our last session. Welcome back, and thank you for joining us for a session that has a very deep personal meaning for me as a hospitalist. We're going to devote our closing hours to talking about hospital medicine, and we'll start with our first discussion with Professor Youngsam Kim. He is Professor of Internal Medicine and at Yonsei University College of Medicine, and he will be talking to us about hospital medicine in Korea.
Thank you for your kind introduction, and it's a great honor to be here and present the current status of hospital medicine in Korea. I do not have finance interest in commercial product and related this subject. I will present my talk with the background and initiation of the hospital medicine system in Korea and the introduction of a special act of the resident from 2017. The hospital's concept begins. The purpose of this act is to improve training environment of resident in Korea and ensure safety of the patient. According to this act, the resident working hours reduced to less than 8 hours per week, like USA, and reduced the night duty less than 3 days per week, and limit continuous working hours less than 36 hours, and keep 1 day off duty per week. When I was a resident, I work about 100 hours per week, and sometimes I cannot sleep about 48 hours, but it has been changed. After the application of the Special Act of Residence, the resident working hours is decreased from 102 hours to 85 hours, about 16%. And simultaneously, the number of the residents in Korea is decreased about 20%. So, new safety issue is occurred in the hospitalized patient. The volume of the work to the inpatient is the same, but the working hours decreased and number of the residents decreased also. So other doctors have to do it. So the concept of hospital is necessary for Korean patient. The first hospice program is launched by Private Pilot Project Alliance, not government first. It is initiated by Korean Medical Associations, Korean Academy of Medical Science, Korean Association Internal Medicine, and Korean Society Surgical Department. After that, the Korean government, Ministry of Health and Welfare, launched official program from 2015. And it is a very important topic, so they organized a task force for Korean hospital systems. And the task force meeting with the Korean government organized the committee and make a policy and reporting it to Health Insurance Policy Review Committee, and Korean government officially implement pilot system first from 2016. From September of 2016, the Korean government started a pilot program. The 31 hospitals initiated this project, and it is on 3 years and report final outcome of pilot system. And finally, the Ministry of Health and Welfare officially implement the hospital system in Korean National Health Insurance System at January of 2021. All the process is published in the Journal of Hospital Medicine as a title, Development and Evolution of Hospital Medicine in Korea. It demonstrates the two topics. In the private organization period, the outcome is increased accessibility to the doctors, increased patient satisfaction with care, and increased patient satisfaction of doctors also. After that, the government derived the project. After that project, it also increased accessibility to doctors, increased patient satisfaction, and increased counseling and face-to-face service. And it's also satisfies the medical staff, nurse, resident, and other doctors. The Korean inpatient care systems are slightly different. The inpatient care fee schedule is charged per day, including all the inpatient care composition. Unlike USA, there's no separate claim for physicians, lab technicians, or facilities. So doctors provide care to the patient and are then paid for the service in terms of salaries. And in Korea, the original inpatient care fee schedule was low and insufficient, so it was difficult to provide high-quality care. So after implementing the hospital system in Korea, led the creation of new fee schedule, especially for the hospitals, so that hospitals could claim hospital fees on the top of the inpatient care fees. There are three types of fee schedules for hospital service. The first one is type 1, we call it type 1, weekday coverage only model. The hospitals are working more than 8 hours per day on weekday only. It is type 1. Second one is weekday and weekend coverage model. Working hours more than 8 hours per day, but do not cover nighttime. Type 1 and type 2 do not cover the nighttime. The type 3 is full coverage model like USA. They cover 24 days, 365 days per year. The fee schedule is different. It is a current status of data of hospitals in Korea. It is reported in March 2021. The number of patients is the number of hospitals of 45 total. In the Tertiary University Hospital, 27 hospitals implement the hospital system. In the General Hospital, 18. And number of hospitals at that time was 235 total in Korea. In the Tertiary University Hospital, 167, and 68 hospitals working at the General Hospital. And the number of wards covered by the hospitals, the total number is 103. And Tertiary University Hospital, they contains 72 wards. And in the General Hospital, 31 ward was covered by hospitalists. I'm sorry for the Korean, but the yellow one is type 3, and nighttime coverage. After the main program, the type 3 full day coverage was only 5 or 3% only. The most of the hospitals, the fee schedule is the type 1, weekday only. It is a big problem now. And the Korean hospitals are working very hard for increase promote their system. So under the Society of Internal Medicine, they organized the study group for hospital medicine and is a member of that committee. And you can meet Dr. Shin. Dr. Shin was the first president of this study group for hospital medicine in Korea. The study group is working very hard to promote the hospital system and launching the hospital system in Korea also. And some hospitals consult and sponsor the dramas. It is in Korean name, 슬기로운 의사생활. Wise Doctor's Life is a very, very famous drama for Korean doctors. And some hospitals consult and sponsor the drama to promote these systems. Now the patient, doctors, and hospital associations and government are all agree with the need for this system and organized special committee for hospital medicine under Korean Medical Associations. I was committee chair of the hospital medicine under Korean Medical Associations. They are also working now. So they have an active role implementing this system officially in the government health insurance systems. And the salaries of the hospitals increase very rapidly now. But there are few applicants now. The most hospitals cannot recruit the hospitalists. It's a big problem in Korea now. I don't expect the future of the hospice, but I adopted this slide from the Evans. I agree the best way to predict the future is to create it. So our role is create our future. There are three components of the hospital system implementation: hospitals, patient, and doctors. And in our hospital, we want to clear the job scope and job description. And we implement the reasonable reimbursement system to the national health insurance system, but it is low. We increase the reimbursed level. And the doctors have to make a vision and make effort to expansion this system nationally. It is a conclusion. National implementation of the hospice model represents a key paradigm shift in Korean healthcare systems. The Korean hospital system is a result of hospitals, doctors, and patient desire for higher quality of care. We expect to see growth of hospice in Korea and provision of better, safer, and more efficient inpatient care across the specialties, payers, and government. I hope the number of hospitals will increase rapidly. We started at around 100 2019, and we hope increase rapidly and cover the Korean inpatient care. And we hope our implementation process of a new medical system could serve as a model for other countries who are seeking to adopt hospice system within their current healthcare paradigms. And I expect, thanks to Dean Augustine Che, we can start the collaboration project from 2018 due to MOU signing, after the MOU signing ceremony between Weill Cornell and Yonsei University. And also after that, we get the big support from the Cornell teams, Evans and Jennifer and Justin and Alan Kim. Yeah. This is the final slide. We can go further when we go together. Thank you for your attention.
Thank you, Professor Kim. I do also need to mention that Professor Kim is a special member of the CAMA Convention Committee, and he has spent countless hours to ensure that we all arrived safely. And truly, the CAMA team is indebted to you. Thank you. Next, I have the distinct pleasure of introducing my boss, Dr. Arthur Evans. He is the director, the chief of the section of hospital medicine at Weill Cornell Medicine. Thank you.
It's a great honor to be invited to speak at the 46th CAMA Scientific Convention. It was also a great honor to be selected by the dean to join my colleagues, Jennifer Lee, Annie Kim, and Justin Choi, in being part of the Yonsei Weill Cornell collaboration. The goal was to help establish Yonsei as the leader of academic hospital medicine in Korea. It started in 2018, so it's been interrupted a bit by COVID, but we managed, and we'll speak about how we managed through COVID shortly. It was supported by the deans of both Yonsei and Weill Cornell. This is a picture of our first collaborative meeting in Seoul. You'll recognize several of the faces here. This is many of the original hospitalists at Yonsei. There's not many. And it's grown 8-fold since 2018, so tremendous growth. And even though at Weill Cornell we started hospital medicine in 2009, so only 12 years ago, we're fairly new also. But if you think about the models of economic growth in South Korea over the last 3 decades, and you think about the growth in scientific advancement in South Korea over a similar time period, there's no doubt that in the next 3, 4, 5 years, South Korea is going to advance faster than the US has, and they'll be coming to the US so that we can achieve that goal of being the best in the US in hospital medicine. So there's no doubt in my mind that that's going to be the next step in this collaboration. Part of the structure of our collaboration was a faculty exchange, and there was a part where South Koreans came to New York, and Dr. Nam, who had just finished his training in nephrology, stayed with us for 1 year, and he participated in our hospital medicine clinical scholars program, which is our version of a fellowship program in hospital medicine. And others of his colleagues came for shorter visits during that first year and a half. Here's a picture of 3 of the members, Dr. Nam on the far right, Dr. Kim, Dr. Park, meeting with our dean, and then the associate dean for international affairs, Mickey Stewart. And then there was also faculty exchange of our faculty going to South Korea. And we arranged 4 one-week visits per year where 2 to 4 of us would go, and we participated in a curriculum. The picture on the left is Dr. Lee sort of leading a exercise about creative teamwork using marshmallows and spaghetti. And then I'm teaching on the far right something much less fun. And our goal was helping the Yonsei group achieve excellence. And I put some of the requirements here: recruitment, training, and retention, all very important, but inadequate. Because there has to be support, infrastructure, there has to be mentorship, there has to be sponsorship from the leaders of the hospital, the institution, collaborating groups. Because regardless of how much effort and training, expertise the individuals bring, hospital medicine is a team sport, and there has to be collaboration, good collaboration with nursing and with other professional colleagues in the hospital. And if that doesn't happen well, it doesn't make any difference about recruitment, the training, or the retention. And so that's a key part of something that I learned, and I took for granted almost because of the great support I have at Weill Cornell. That's a huge effort and part of the developing successful hospital medicine programs is a committed leadership in the institution that can help build the appropriate infrastructure for success. We did a needs assessment surveying the hospitalists. We also did that speaking with the residents. And as part of that needs assessment, we developed with our Yonsei collaborators a curriculum. The first was how they can develop their own faculty development program or on-the-job fellowship training. We also helped focus on improving clinical teaching skills, clinical reasoning, clinical epidemiology, evidence-based medicine skills, bedside ultrasound, and a foundational skill in hospital medicine, which is quality and patient safety and system improvement. And then speaking a lot on teamwork, leadership, and mentorship. Here's a picture of Annie Kim teaching about the history of hospital medicine and how hospital medicine programs are structured, organized, and their standard operating procedures. A picture of Justin Choi teaching point-of-care ultrasound. And here I'm teaching clinical epidemiology. An enjoyable part of the collaboration was building teamwork across our two universities and building our relationships and trying to model how a supportive, collegial environment is so important to success. During COVID, we were unable to travel, of course, but we continued to have virtual visits. We met with medical students over Zoom. We met with the hospitalists regularly and had additional educational programs. And of course, it had to revise our timeline. I've listed here some of the important remaining questions that we as a collaboration need to address. And one is, should there be a formal or informal fellowship in hospital medicine? Now, in some ways, that can help surmount the barrier of respect with subspecialty colleagues. In pediatrics in the US, it's a requirement now, if you're going to practice pediatric hospital medicine, to complete a fellowship. For internal medicine, that's not necessary. And I think in Korea, I think there may be an option to either do something informal, where you set something up where you have an intense faculty development program, or a formal fellowship. Second question is, how can we facilitate more scholarship? Again, if we're going to be equal partners with specialty colleagues who are expected to do scholarship and get extra training in scholarship in their specialty field, how can we achieve that sense of equality and respect among our colleagues unless we can also do scholarship? There's plenty to do scholarship around. The question is there time? Is there money? Is there infrastructure? Is there sponsorship? Is there mentorship? That's require a lot of extra work. Should there be a randomized trial on the value of hospital medicine? It can't be done in the first couple of years. It requires, if you're going to really test its true value, you have to have some experienced hospitalists who know the system, who are trained, and have effective teamwork in the hospital. But maybe that issue is past, it's moot. Maybe it's not needed. And then another question is how to best organize co-management services. Hospital medicine has a lot of both formal and informal co-management services. I'm going to speak on this on our Saturday hospital medicine conference in more detail. But no matter how good the hospitalist is, their work in the hospital will fail or be substandard unless there's good teamwork, unless there's mutual respect with the physicians they're working with the nurses, with the house staff. And how you organize those co-management services is crucially important and requires the involvement of hospital and departmental leadership. There's also going to be need for hospitalists to do innovative things in co-management. In particular, I think that the next co-management frontier is hospitalists co-managing with robots, and who will serve the role almost like an intern, but smarter intern, who will have these robots will not only help in listening to the conversation going on between the doctor and the patient and helping write the note, but will also be based on what's said, searching the relevant literature and the guidelines about what perhaps the next diagnostic approach should be, therapeutics, prevention, and even remind the physician perhaps about missing key physical diagnosis findings or history items. So I think that's going to be an important co-management service in the future. Part of the expertise of hospitalists is developing leadership in a number of domains, and they're uniquely qualified for some of these roles, whether it's in hospital operations, which is sort of obvious, quality improvement, I've mentioned that, teaching, communication, addiction medicine, palliative care, information technology and artificial intelligence, medical ethics, which are only a few of them. So those are areas of expertise which some of the hospitalists will want to focus and build and become experts in. Now, it's going to take some time, but the growth here that we've seen, going from 7 to 8 hospitalists at 2 hospitals to now over 50 hospitalists at 3 hospitals, has been tremendous. And they have the skills, the determination to be a huge success. And as I said, in 5 years, they'll be coming to New York to teach us how to be the best in the US, just as they are the best in South Korea. Thank you.
Thank you, Dr. Evans. We'll now open the floor and the chat for Q&A. Please enter in any questions you might have. I would like to have our speakers perhaps alternate up to the podium to answer. First, maybe for Dr. Kim. It was truly a pleasure to see some of the photos that you shared. It certainly brought a lot of memories back to when we had an opportunity to collaborate in person, and I think that's one of the reasons why this trip is particularly meaningful for me, to be able to come back and meet the team who's here today. You presented the history of how hospital medicine developed in Korea and also the steps that are currently in place. You mentioned something that was important about recruitment and the challenges that currently face hospital medicine as a medical career track for our graduating residents. Do you have any thoughts on how you would like to address that and maybe some of the underlying reasons why residents are choosing not to do hospital medicine?
The first reason, the hospitals regarded at the first phase as a super resident. It's other types of resident, but it is not good for the implemented these systems. So we are focused on that and address that the hospital is not all other types of residents, super resident, and they will be regarded as experts. So we address that point. All of the hospitals want to be a hospitalist, and in the Yonsei, we will focus and educate the hospitals, be an expert, and they will be respected, and all the residents and fellows want to be a hospitalist. That's an important point. And it is the beginning of the hospital system in Korea. It is not promoted and widespread in the South Korea now, but we will promote and advertise this system in all over the country. It is increased slowly, but we have many barriers to recruit the hospitalists, but the environment has been changed, and the government and hospitals also want to recruit more and implement the more incentive measures, I think.
Thank you. And then maybe leading into that, Dr. Evans, hospital medicine, thinking about the audience and also about where we are and why we are having this focus session on hospital medicine, there's certainly a lot of interest on the Korean side because of the new government mandates. But hospital medicine certainly isn't for everyone. Do you have any thoughts on the candidate that should consider hospital medicine and perhaps the candidate who should not?
think because we deal with so many clinical problems, and especially when there's a lot of diagnostic uncertainty, and there's the emergency department doesn't know exactly who to call, they'll call hospital medicine. So people who are willing to put up with a lot of uncertainty, especially early in the stages of the clinical management, are ones who are going to be drawn to hospital medicine. And then the breadth of clinical care. If they enjoy clinical problems across multiple organ systems, they can definitely be more attracted to hospital medicine. And those are, I think, the two main things, the breadth of interest and the ability to function under uncertainty.
Thank you. And then my final question will be for Professor Kim before we go into our panel. We have established this collaboration now with Weill Cornell Medicine, two separate institutions in two separate countries, but also two separate cultures. Knowing what you know now about what we were able to bring to Yonsei, are there things that you feel will not be appropriate to adapt into a culture like Korea?
It's not by the cultural difference. The other environments are very different. In Korea now, there are a few hospitals, and almost of the faculty members' hospitals is hard work. We cannot save time for educations, and so we need other ways of educations, such as it is online training is also good and appropriate for the Korean hospital system. So visiting is very good, very intense, and the Korean hospital system environment is not good as USA. So we consider combine this online continuous educations, and sometimes we can visit USA and can come to that, but we think the visiting is more effective for us because we can not anything when we were in USA. So we have to consider other options, not cultural difference, the working environment.
Thank you, thank you. And with that, I'd like to thank both of our speakers, Professor Kim and Dr. Evans, for joining us today. Thank you. And I think we will move into our last session of the day here in Korea, our panel discussion. And joining me as a real-life example of the collaboration between Yonsei and Cornell, joining me as a co-moderator will be Professor Dong-ho Shin, who is an associate professor at Yonsei University Medical College. Please join me up here. And I'd like to invite our panelists to please join us up on the stage.
Okay, let's start the panel discussion. I'm Dong-ho Shin of Severance Hospital, and I'm also the president of Korean Society of Hospital Medicine. It's my honor to be here, and thank you for the invitation and the discussion today. And I will introduce the panelists here. Professor Soo-jung Kim. She is the associate professor of Yongin Severance Hospital and the Department of Hospital Medicine. And 직접 하시는 게 나을까요? 그냥 제가 다 설명하는 게 나을까요? Okay. And yeah, please introduce yourself. Just for sure.
It's my great pleasure to have chance to participate in panel discussion about hospital medicine in Korea and collaboration between Yonsei and Weill Cornell Medicine. And I work as a professor of internal medicine in Yongin Severance Hospital and also Yonsei University College of Medicine. And my task was to set up the Department of Hospital Medicine in Yongin Severance Hospital because our hospital was just time to start last year, March. So we are on the way to setting down more systems and more working ways about hospital system in Yongin and also in Korea. Thank you.
And Professor Ki-hyun Nam.
My name is Ki-hyun Nam, and I started working as a hospitalist in 2019, and I was lucky enough to experience the novel training program at Cornell 2 years ago, and I'm still working as a hospitalist. Thank you for having me.
And Professor Justin Choi.
Good afternoon and good evening. It's an honor to be here. My name is Justin Choi. I'm a hospitalist and assistant professor at Weill Cornell Medicine, and I'm happy that we're able to share our experience, which is not too much older than that of Yonsei, but certainly is not as familiar to most of Korean medical society.
And Professor Arang Kim.
Hello again. My name is Annie Kim. I'm a hospitalist at Weill Cornell since 2017 and assistant professor of medicine at Weill Cornell. It's been a real pleasure and honor to be working with our collaborators at Yonsei on this joint venture in the last couple of years. I've learned a lot through our collaboration and look forward to working together in the future.
Okay. In Korea, the history of hospitalist is about 5 years. 5 years from now. So some hospitalists now considering if they can continue their career as a hospitalist or stop and change it to other career path. So these problems and questions are very important for us. So I wonder, I would like to ask you that what would be the biggest hurdle in continuing a hospitalist career, and what makes hospitalists consider quitting their job? Can you start from the Cornell panel?
Yes. Well, so this is going into my 5th year as a practicing hospitalist, and I do wonder about the sustainability of being a career hospitalist. Again, hospital medicine is fairly new as a specialty in the United States, just about 20 or 25 years old. So we don't have many hospitalists who have practiced for decades, as is the case for other specialties. So I think the nature of hospitalist work can be quite demanding with the patient load, the number of hours, and increasingly so in today's pandemic, where hospitalists are frequently on the front lines. So I think burnout is certainly a concern, and it's probably not unique to hospital medicine, but I think we should find systematic and a broad range of strategies to address burnout in hospital medicine.
How about Aaron Kim?
You know, I want to say I feel very fortunate to not have experienced the desire to quit hospital medicine as of yet. And I personally can't think of many hurdles that I'm facing at Weill Cornell, but you know, looking around in other New York City programs and elsewhere in the country, in the US, I see a lot of hospitalists are getting burned out because of very high workload, number of patients that they have to see in a day, extended hours they're working each day, and the lack of support they're getting from their leadership in terms of working environment or other interdisciplinary team members that are there to support the work, the clinical work that these hospitalists do. So I find that it is very important for leadership support, for ancillary support, to make hospital medicine a viable and a sustainable working environment for all.
Is somewhat, I feel reassuring, or no, I feel okay that you, it's good to hear that you feel the similar experience. So we are not alone. It's very good to hear that, but it's also frustrating at the same time because you have similar problems after more than 20 years experiences, right? Professor Nam, how do you feel your situation? Can you, if you can continue your career as a hospitalist?
Yeah, I totally agree with Justin Choi because I think burnout is the highest. I mean, talking about common barriers, burnout is the highest among Korean hospitalists. As many of you know, as we don't have residents or PAs, we have to do so many things that could be done by residents or PAs in the United States. And burnout is also very challenging, especially in our hospital, because we admit very complex patients with a lot of comorbid disease. So, and I found when I was in New York, when I was at Cornell, that many physicians, including hospitalists, are interested in burnout and resiliency issues. And some of them were doing projects or research on that issue. So I think many Korean hospitalists should pay more attention to this issue to develop more sustainable models. And some of us should start research on this issue and come up with solutions on both personal and institutional levels.
Yes.
Well, I totally agree with the opinions of Professor Choi, Kim, and Nam. But in Korea, the history of hospital medicine is on the way of just on the start line. So most of the hospitalists are the doctors who have moved from their previous major fields. Like for me, I have moved from hematology to hospital medicine, and for Dr. Nam from nephrology to hospital medicine. Because in Korea, more than 95% of internal med doctors have a specialized board like oncology or cardiology or nephrology or so on. So when they choose or change their directions to hospital medicine, the other surrounding of their neighborhood or their colleagues, prior colleagues, just to think about them, they had neglected their major fields or they have chosen the easier way to work. And the important thing for hospitalist group in Korea to have a more long career path, I think the first thing to be changed is that changing the insight about the hospitalists. We are not the group who have chosen easier way, but we have choose this way to make better hospital and safer operating system. But in Korea, yet we have another view of the thinking that hospitalists are just one of the person who can just work as a resident or interns yet. So if we are to make hospital system to be more strong and concrete and the fundamental system of the medicine, we first have to change is the insight about the hospitals in Korea.
Thank you. Maybe leading from that last comment that you made, Professor Kim, and starting with you to answer the question, what are some steps that you feel Korea should take or that we can take as hospitalists in Korea to address that issue, to address the issue of burnout and address the issue of the barriers that are taking place within the system and within hospitals themselves? And starting with Soo-Jung Kim.
The burnout problem, I think, is different from taking self-confidence. Also, if the patient burden gets much bigger or higher, or the sicker patients get much more number in whole group I take for the care, that will be the problem. But in our field, in my experience, for a very short time, it's only 1.5 year experience about setting Yongin Severance in only 500 bed small hospital. The first thing we had to make was let them have insight of ourselves. Because the member of the hospital medicine need to have that we are not just doctors. We are the doctors. So we start with that, and that kind of changing the thinking made to prevent the burnout. The mental burnout. So different, separate from physical burnout, I first think that a mental burnout, that I just act or work different from other specialized board doctors, is the important thing to prevent burnout and let them select the hospital medicine for their long-term career.
And Dr. Kyan Nam, what do you feel is the next step to help to face that problem?
For our hospital, we should introduce like PA-like system at Yongin Severance Hospital. So again, in Sinchon Severance Hospital, we don't have any residents or PAs, so that's why burnout issue is very challenging, especially in our hospital. And also, I think that as the hospital medicine system in Korea further expands, the number of hospitalists will increase in the future, then the workload for each hospitalist will somewhat decrease. But then I guess what happens next, the hospitals, many hospitals in Korea will give hospitalists pressure to generate sufficient revenue. So I think we need to show our hospital medicine group value other than like money. So we have, as Professor Kim mentioned earlier in this session, we have just few research investigating the effects of hospital medicine system. For example, the pilot project study revealed that the improvements in patient satisfaction and patient safety, and other previous studies show that the hospital medicine system was associated with shorter lengths of stay and fewer ICU admissions. But the positive, fewer results have been quite positive, but we have only few results because the history of hospital medicine in Korea is very short. So I think further comparative outcome study focusing on like patient safety, quality care, or patient satisfaction are needed to further facilitate support from the government and hospitals, because our hospital leadership is quite supportive to us, but there are also other hospitals that are not that supportive to hospitals. So we need to prove our group's value. We need to show that hospitals really truly improve the quality of care and patient safety, and that'll be another next step.
Thank you. And then maybe a little bit of a different approach to the issue for our last two panelists, Dr. R.M. Kim and then Dr. Justin Choi. Knowing what you know, and since you do have more experience as hospitalists than our Korean colleagues, are there recommendations that you can present or share on how, just based on your personal journeys through navigating what a hospitalist is, personal recommendations you can share about how you overcame burnout or are dealing with burnout?
I think as a hospitalist, or even before becoming a hospitalist, I found it very important to have a life outside of medicine and to be in touch with friends and family who are not in medicine. I found that really grounding and helpful. But recently, since the pandemic and the burnout related to the pandemic and increased workloads throughout the COVID crisis, I found a lot of solace and reassurance from my colleagues. It was very reassuring to know that we were in it together. We were all experiencing similar issues of stress and burnout, but we had each other's backs, and having transparent communication with my colleagues at work was very helpful. And I think other ways that I myself have improved my resilience in work and seen other colleagues do the same is through finding an area or a topic of interest that really fuels vitality at work. For me, that happens to be medical education, and I derive a lot of energy and joy from interacting with my clerkship students as well as my residents, and that kind of drives me forward and makes me want to become a better doctor, a more resilient role model for my trainees. And that topic or area of interest might be different for someone else, but having that not only fuels your self-motivation to move forward and to continue working, but I think it also kind of creates a really nice image of hospitalists who have diverse interests, who are dedicated to furthering the field of hospital medicine, not only through clinical work, but also through other academic endeavors. And in a larger picture, I think it really helps myself and others feel proud of being a hospitalist and being a part of this larger community.
Okay. Choi?
I agree with Dr. Kim. I think camaraderie is critical, and there's no way of getting through a day's work without the support of your colleagues. I definitely agree that finding an area of expertise to develop is critical, and it touches on what Dr. Nam was saying in terms of showing your value to a system. And then I guess I would also add what was mentioned in the earlier panel on women in medicine is seeking and finding a mentor to not only show you the way, so to speak, but also having a person with perhaps institutional experience or just career experience that you can confide in and share your challenges and frustrations. And so I feel fortunate to have both a mentor in general internal medicine and also a non-hospitalist mentor to turn to in sort of difficult times. So So I think mentorship is important as well.
Okay, thank you for the sincere discussion. I'm sorry that I should announce that it's time to wrap up. Do you have any last comments for today's discussion? Anybody? No? Okay. Okay, thank you for joining us, and thanks to Kama again for this nice and well-organized discussion time. And I hope we will get together again soon, and for another discussion and some progress and another collaboration program for the hospital medicine system in Korea and America again. Thank you for your attention. Thank you.
So thank you for everyone for joining the second day of our Kama Scientific Convention here in Seoul, Korea. And please join us tomorrow when we have our sessions with our KAMSA and KAMRAF, the medical students, residents, and fellows. Thank you very much.